you all for this excellent meeting session called Spotlight. So Spotlight is a program which is just advanced and comprehensive understanding of lower extremity trauma. So this is an half-day program. We will be having an excellent faculty today from Israel, Dr. Yaacobi. He is a renowned surgeon in their part of the region, and he is working as a deputy chair orthopedic department at Mir Medical Center, and he has a lot of experience. He has done his professional AO fellowships and kind of faculty training program, and he is a faculty for AO at various levels. So he's he's working in a high trauma center. So he will share his great experience today with us all. So we have Professor R. Sivakumar sir, who will be also sharing. We all know that he doesn't need any introduction. So he will share his experience. We have Dr. V.S.V. Kumar today from SIMS Chennai. So he will also welcome you, sir. So he will also share his experience, and Dr. Krishna Kumar, and also we have several faculties of us from Preethi Hospital, Dr. Bharat, Dr. Vinoth, and Pratik, Arul. So we all will share our experience. So I think so without wasting much time, I welcome you all for this wonderful noon program. So enjoy the scientific course. So over to you. So it is a discussion we are planned for hip session, knee session, and ankle session. So we have a couple of talks. So we want to make it more interactive. So we are doing a case-based discussion. So the faculty will also share some interesting cases. So be more interactive. Try to see if you can have any doubts, if you have any similar case where you had some difficulties. Be open, and because this is a very close meeting, we are all there to share your experience and make use of this to the most. Thank you.
Thank you, sir. We will start with our first session. First will be a hip session. First, I would like to call Dr. Yaacobi to speak about the management of acetabulum fractures, tips and tricks. Regarding Dr. Yaacobi, he is a deputy chair orthopedic department in Mir Medical Center. He is a AO trauma faculty member, and presently he is a regiment head medical officer. He did various fellowship in USA and UK and Switzerland on AO trauma. His memberships are AOS International, AO Trauma Europe, and Israeli Medical Association. Please come, sir. Thank you.
Hello everybody, thank you for having me. It's a pleasure to be here. Well, tabular fractures. I think when you talk about, I'm sorry, I'm regular to moving all the time when I'm presenting, so if I'm here, can everybody hear me? Is it okay? All right, perfect. Well, no, I have a high voice, it's fine. Thank you. Well, if you talk about trauma surgery, I think one of the worst fractures for us to understand and try to understand what we're doing and operate and fix is acetabular fractures. It's the most.
We are doing live streaming.
Okay.
So if you speak in mic.
Oh, sorry. Okay.
Check.
No, so I'll stay here. I'll stay here. Okay? All right. Now we're all set. I'll just put it here. I'll put it in my back pocket. All right. I hope now we're all set. So before we can even start talking about how we fix it, how we operate it, and what we're doing, we need to understand the fractures. We need to understand their shape. We need to understand the anatomy. So this is the first step. And how we understand it? Well, it's complicated. Even us experts, if we'll sit together, 3, 4 experts, we'll see a picture, we'll see an X-ray, we'll see an anatomy, we'll start to argue each other. What's the exact classification, what exactly the shape and how you will treat it? There's no one way for it. So we really need to try to simplify what we see there. And remember the first theory. The slingshot theory, the Y shape acetabular beam, or how it gets its support from this Y shape. Well, there is some sense to it. I don't really buy it, but we did take from it the concept of 2 columns. And the 2 columns are important. Unfortunately, they do not implement the whole pelvic area. They do not implement all the regions, because we try to look at the acetabular. We have 2 columns, we have 2 walls. We'll speak about the walls first, but there are some regions they forgot, and there are important regions, and they take part in our shape of our fractures. Now, there isn't, although we do have classification, we do know the posterior column, the anterior column, the associated fractures, the hemipelvic, the hemiposterior, the anterior column, hemiposterior. We all describe them, we're all telling them, but each patient is different, and we have to understand that this column miss these areas, and we have to look at the pictures and understand what we're looking at when we describe it. So the first step is looking at the X-rays, and I highlighted here the blue. I'm sure you all know it, the iliopectineal line, the ischial iliopectineal line represents the anterior column, the ischial line represents the posterior column. You see the walls with the white and dark areas. You see the dome, very important shape. People don't always give it consideration, but this is one of the first areas I looked for, because remember the gold sign? The gold sign is the sign which for bad prognostic for the patient. And when you have the bad prognostic signs in acetabular fractures, you should think how you should treat this patient and what will be the result at the end of it. The teardrop, well, I'm sorry, until today I don't really understand it's important, but it's there, we describe it. But I don't know why. Yeah, that's what it is. It's this fossa, the cutelloid fossa. Never used it, don't know, but it's there. Okay. We do have our radiographic, the obturator view, and the iliac oblique view, which really helps us to describe the anterior column and to describe the posterior wall, and the other side, the posterior column and the anterior wall. We can also see, you know, the iliopectineal, the oblique iliac view is to describe the posterior column, but I think we see beautifully the anterior column. And if you really want to know the shape of the anterior column fracture, you have to look at it in both first. So I know when they examine you and you have a question, they tell you this is for posterior column, this is for anterior column. No, both pictures are for both columns and both walls, because you can see a lot of information if you use both of them. But eventually, we have to describe it. We have to give it names, because when you call, you cannot always send by WhatsApp the pictures. You have to tell your on-call physician what you're dealing with. Now, when it comes to classification in acetabular, it's a mess. It's a huge mess. If anybody will ask me today, how do you describe it? There's not only the Le Tourné classification, there's a lot of them, but we need to understand when we're talking about, there is some sense in the associated fractures and non-associated fractures. when you describe only the anterior wall and only the anterior column and only the posterior column. Why? Because you have to make your plans in the future. You have to make the plans afterwards. How do you want to approach this patient? How do you want to operate about him? And we'll talk about the surgical approaches later, but this is what, in basic, in all regions of orthopedics, you use classifications not only to describe the fracture. You use it to know your energy that you fractured it from in some classification, to know your way of treatment, which is the most important thing, I think, for classifications, and for research purposes, so we can talk in the same language when you write what you're writing about. Now, the Le Tournier classification is the most famous one, is the most used. If you check the literature, you'll find, I think, maybe 10 more classifications. Now they started to do different classifications for elderly patients and different classifications for younger patients, and divided by age, but still this is our working horse, but it's not accurate. This is not the only shapes that we have in our classification. There is a lot of different lines going for the different type of fractures. So it's not completely accurate, but we do use it. We do use it. So after, where do we go from here? What do we do with all this information? Well, we need to treat the patient. We need to understand this knowledge and to implement that. And sometimes we look at the pictures, we're not sure what we're seeing. It all looks pretty nice, and then you CT scan them, and the CT scan is very important, because I think eventually today we do have the tool of a CT scan, and gives you a lot of information. And we have the 3D reconstruction that gives you even more information. But if you start to implement this workflow, you'll only get confused. So look at it, it's nice, leave it alone. You have the steps, how to recognize everything, where is the fracture line, how to implement it. I'm not going to go into it, because I'm getting confused only from reading it and giving it to residents. Just what I think you should do, you should look at this. Start with the CT scan. The only thing I can teach you, start with the axial view. When you start with the axial CT scan, even before you do the 3D reconstruction, start with the axial view. This dome view, when you look from above on the dome region, it's one of the most important slides in the CT scan, where you can see your fracture line, one go horizontally, one go vertically, and you can know the shape. Even before you do the 3D transverse fracture, or start with the axial view, only by looking at this dome view. We look from above. Now, on the dome region, go a little bit further down, and then you'll see your wall fractures. They are oblique lines. Go to the region of the head, and you'll see these oblique lines, and you'll know if you have associated wall fractures. And it makes it easy to understand. Today, we have even more tools. If you really don't know what you're dealing with, do a 3D reconstruction. I don't know how many of you have this in your facilities. I like to play with it. Do the augmentation in really complex fractures where I'm not sure what I'm going to do. It's easy to teach residents with it. It's easy to touch it. It's easy to put plates, sometimes bending the plates accordingly to what you want to do. And it can make your life easier. You cannot implement it on everybody, but today it's even available almost everywhere. So about our approaches. So we have our working horses, which is the stopa, or the anterior ilioinguinal, the anterior intrapelvic approach, with the modified stopa, which was called until now. Now we call it the anterior intrapelvic approach. We have the Kocher-Lagenbeck, the posterior approach, which are the main working horses for acetabular fractures. But before we start to open the patient, we have the minimal invasive approaches. And screw fixation, I think we can do much more with than we actually doing today. With the aid of navigations, we can fix much more acetabular fractures only by screw fixation without opening the patient. And you have the anterior column screw, which can go antegrade and retrograde. The rule of thumbs is if your fracture line is laterally, go for the anterior. screw. If your fracture line is more medially, go for the antegrade screw. The posterior column screw, a bit more difficult, not that of a minimal invasive, because you have to implement a lateral window in order to reach it safely without pinching any major vessels on the way. And you have to find the right golden spot on the antegrade screw. It's a bit difficult. It takes time to learn. It takes time to implement. You have to make sure on the C-arm that you're in the right place, and then scan it afterwards, because you could be positive you're spot on, and then you scan it and say, oh shit, I'm way off. It's not what I thought. Doing the retrograde screw, it's easier to find your corridor. It's easier to find your way inside the posterior column corridor. The problem is, you know what? The problem you here? You're operating through the ass. We don't like to operate through the ass. It's not common that the resident have to bend the knee and the leg and raise it, and you work something like this. You have to bend over. Not very comfortable, but it's easier to find the right spot, the golden spot. And if you do it right, you can work your way with displaced fractures, reduce them closely, and put the screw and get amazing result if you do it right. And how to do it right? One of the things we have today to do it right is navigation. I'm a big freak of navigations and new technologies, maybe because I'm coming from Israel. I'm not sure, but still, I love to play with this stuff. So you see here, this is the O-arm S7 navigation. It's very easy to implement. It's very easy to use. You use inside the OR. It gives you very nice result. The problem with this, it's designed for short screws, not for long screws like we use. So you can see your beginning where you're going to, and the system starts to a little bit get confused when you ask her to look further away. So what I'm working on today, it's augmented reality navigation. It's where I can do my navigation through glasses, see my CT scan on the patient. I can do my planning. I see the CT scan and the screw that I want to put, and then implement it quite easily. It's still in development. It's not something for the market, but we have in great result, and this is how it looks from the glasses. This is the Microsoft HoloLens glasses that we use. I do it with an American company called Novorad. And I have these 3 pictures to navigate like any NPR pictures, and I have the CT scan, the slice that I want to do, and this is my screw that I'm aiming on, and it's like shooting a laser gun to the right spot. It makes life easier, but it's still in development. You can see how it looks. It's very nice. This is my guiding tool that I put, and this is the aiming picture that I will get where I need to go. Okay, the open approaches. So pelvic there's a huge learning curve when you're operating on pelvic fractures. It's a huge anatomy, a lot of blood vessels. You have the bladder there. We don't like to see internal organs. We're orthopedic surgeons. Bladder, come on, guys. And we have huge vessels, and it bleeds all the time. And when I was just coming back from a fellowship, my senior trauma surgeon, he didn't really like the pelvic operations. And every time he come in with me, I used to make like this small bleeding, and he would see this bleeding and say, okay, it's enough for me, and go out and tell everyone, now we can start. He's out of the room. So it will always bleed. Doesn't matter how much you try, you will always have some bleeders there, and you have to go really, 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 really careful. So the working horse today is the anterior interpelvic approach, especially for anterior column fractures. Also transverse fractures, T-type fractures, associated fracture, anterior and posterior column you can do, but if you have posterior wall, it's a problem. It's not really your approach to get there, but most of the job could be done from this approach. You can implement the lateral window, which gives you a good help to reduce if you have an iliac wing extension, you can reduce the iliac wing extension and implement your plates and make life easier. The ilioinguinal approach, well, I saw it maybe twice during my fellowship. I did it once on cadaver. I'm never going to do it myself. It's true, it's better you have 3 windows instead of 2 windows in the modified stopa or anterior intrapelvic approach. You have 3 windows, you see better, you can reach better, you can do a better reduction, but the dissection and the work you have to do on the dissection of the inguinal tunnel takes a very long time. And I don't really think that the advantage of it really it's really worth the time you have to invest on the approach. And I don't use it. I know most trauma surgeons don't use it anymore. There are some senior Cheap Route, Professor Cheap Route from Dallas is still using only that. He's one of the gods of pelvic fractures. Everybody that does pelvic fractures knows about Cheap Route, and I met him a couple of times. I visited him. He's a very nice guy, but for him, this is the only approach. But it's okay, because this is what he knows. He knows to do it fast. He knows to do it well. I'm not doing it. The Kocher-Lagenbeck is our workhorse for posterior fracture, posterior column, posterior wall. Very easy to implement. Quite safe approach. If you take the sciatic nerve away and you protect it, after that, you're pretty safe. Not too much structures to injure, but you could do some posterior column or transverse associated posterior wall fractures. I did a couple of times where you can reduce through the greater sciatic notch, you can reduce the transverse fracture and put an anterior column screw and fixate it, and then put your posterior plate on the posterior wall and posterior column. But it's a bit more difficult. I really try in my practice not to do 2 approaches. I'll do whatever I can to avoid flipping the patient and doing another approach. So let's look, I brought like 2 cases, I think, so we can go over through. So you start with the x-ray. You don't always have the x-ray, because today what happens, it comes to trauma room, CT, total body CT. And the total body CT is very bad for us, guys. Do not agree for only total body. It's important, but it's not good for us. Why? Because it's a vascular CT. You don't have the small cuts of a bone scan. They do give you some bone reconstruction, but it's not the same quality, it's not the same thing. So you see here, you see the spur sign, you see the gold sign. You know, this is a very bad prognostic for this patient, but this is a young patient, so what can we do? He's an active patient. You want to try to save him as much as you can, to give him a nice joint. So you do the CT scan, you do the 3D reconstruction, you can see the transverse fracture, you see the T-shaped fracture, you see the anterior column iliac wing extension. Now, one thing about this case, that's why I brought it, you can look, it's not a complete fracture of the iliac wing. This is a problem. You know why? Because this fragment will not reduce. The anterior column fragment, if the fracture is, it means like you have like a plastic deformity with the children. You get a plastic deformity, and this fracture will not want to reduce. And sometimes you just have to go lateral window, break this thing, make it a complete fracture, then everything reduces fine. So this is what I did. In this patient, I used the S7 for navigation for the posterior column screw, because I already had the anterior approach. I had the lateral window, suprapectineal plate to fix it all, and I think he received a very nice result with good function. You can see it afterwards. The joint looks, although we had all the bad signs, you can see the joint looks pretty good. Second case, bit shorter case, I didn't have any x-rays, I had only the CT, so I put it directly into the planning app for the augmented reality navigation. He had it, it's a tabular fracture with sacral fracture. This is a shape of fracture we don't see every day. So I planned the SI screw to navigate the SI screw and then to deal with this acetabular, both column, posterior wall, fracture, pretty comminuted fracture. So I went into the OR, did exactly that. Did the SI screw, anterior suprapectineal plate, fixed the iliac wing, flipped the patient, unfortunately, and fixed the posterior wall. Thank you. Any questions? Thank you very much.
Thank you, sir. That was an excellent session. Any queries from audience?
Very nice deliberation.
Thank you.
I would like to ask a few questions, like what difference you made in augmented reality than the navigation in acetabular fractures fixation? Because you said S7 you are using, and in the Medtronics and in the Striker, you said, but still you said you wanted to go to the augmented. What difference you made? What exact difference you made in that?
So two things why I'm doing it. First, because I like to look for new technology all the time and try to implement new technologies and to see how they can make our life better. Second of all, the implementation of the navigation when you don't have to bring in the arm, do one CT scan, then do a second CT scan. It's a lot of work to implement the S7 because it's uncomfortable. Sorry? Okay. And so that's the second problem. The third problem, it's I need to fight with the spine guys for the OR. Okay. And unfortunately for me, we have the same OR days and the same OR times. So I did this still for them, but they cannot. Today we reached a point where you take the arm away from a spine surgeon, he's blind. He has no idea what to do. You know, I remember there was a day that I saw them all freaking out and nervous and didn't know what to do. Tell them, what happened, guys? Tell them, the arm is not working. Tell them, okay, so do it freehand like you used to. Say, no, we don't want to. So they're really, this is one of the problems with navigation. When you get so used to it, you get obsessed about it, and you forget the old ways. So I will never do navigation when I teach a resident how to do SI screw. Because SI screw is pretty straightforward, and it's a basic type of screw to do. And I think most residents need to know how to do it. Now, it's not anterior column, posterior column screws, a bit more complicated. Even for me, it takes a little bit of time to make sure I'm in the right place. But SI screw you have to do, and I will always allow them to do it without navigation. I might play with the navigation and see that it's working for me, especially with the augmented reality, because I have to collect cases. We have to continue with our learning curve. And I'll see that it's spot on and it's in the right place. I take everything out and give the resident, tell them, okay, now you have the image intensified, you do it again. This is the way to learn. There's nothing you can do.
And from the cases which you have presented, maybe the take-home message is in the case of bicolumnar fracture of the acetabulum, where it's a bit complex or associated injuries are there, you go and address the complex injury first by a regular open method, and you go to the next column by some minimally invasive approach. Can we take it like that? Because the cases you showed and the way you presented, what short, crisp message you would like to give us?
you have to get into reduction. You always need reduction first. There are some, in trauma surgery, there are some ways we know how to use screws or use plates to make reduction. In the acetabulum, it doesn't always work. You have to make sure that you have the right reduction and you hold it in place, then you can put your screws to the places that you do not reach. Like if you do an anterior approach, you want to fixate. If you reduce everything from the anterior approach, your transverse segment, you will reduce it, it will reduce the posterior column. It will put it back in place. You put your plate, you put everything, you buttress everything, and then it's in place. But you do want to put some support to the posterior column, so you will implement the posterior column screw. You always do reduction first, then fixation. It's not a radial fracture. Radial fracture, you can use the plate to do the reduction. But it's not the same here, unfortunately. It's not the same thing. Thank you. Any other? All right. Thank you, guys. Thank you for having me.
Thank you, sir. Thank you for sharing your insights on navigating trauma. And next, I would like to call upon Dr. Preethi to speak about intertrochanteric fracture tips and tricks. Here, Dr. Preethi M. Rathod, he finished his junior residency and senior residency from prestigious institute, PGI Chandigarh, followed by fellowship in arthroscopy and sports medicine from Fortis Hospital and fellowship on arthroplasty from Osaka. Currently, he is working in our hospital in the division of trauma and arthroplasty. Thank you, sir. Please come.
At the outset, I would like to thank Preethi Hospitals and Johnson & Johnson for giving me this opportunity to be here among the doyens of trauma surgeons. Here are my few cents about what I have gained as a guidance, mentorship, I learned through the books, seen senior surgeons perform. Some of the things that I've read through papers I have all put in slide for you. So I'll be speaking about dozens of tricks to remember to get the IT fracture right every time. So most of my talks will be based upon these two papers, which are the breakthrough papers in our literature. One is in JBGS and other is an editorial board paper from Indian Journal of Orthopedics. As you see, the first thing that we do after getting a confirmation of a surgery for IT fracture is the positioning. Unless you put the torso in 15 degrees of angulation, it becomes very difficult for you to access the proximal part of the femur, especially while reaming. And this is more common in patients who are obese. So it's necessary that you give 15 degrees of tilt in the torso. At the same time, you should not give more of traction, which may cause pelvic tilt. So my trick is first take a pelvis AP X-ray and then give a traction and take an X-ray again to confirm that there's no tilting of the pelvis. Once you do that, the next thing that we go is to see the seamless nature of getting a C-arm, that is both in AP as well as lateral position. So here the image that is depicted is the scissoring image, but we commonly use is the lithotomy position of the opposite limb. So that way we are able to seamlessly get AP and lateral imaging. Once we get that, I still remember my mentor, my boss, my previous boss used to say that, do not scrub until you get your fracture reduced. So you need to get the fracture reduced before you go and scrub into the OT. So most of the time, that is 70% of the time, you get it right. You see that the medial cortical line is in continuity, and you see that laterally you have a continuity in the anterior cortical line. But the 30% of the times, you don't find the reduction. So what do we do? That is when you employ various techniques. You either use bone hooks, you use reduction clamps, or you use Hohmann retractors to reduce the fracture. While you are doing the same thing, the next thing that you have to do is hold the reduction. So when you hold the reduction, it solves most of the torsional forces that are occurring at the fracture site. The most common I use is anterior K-wires. I preferably use more than one, that is I usually use 2 K-wires, and usually they are put in the anterior cortex so that they never impede in my other nail purpose. If I ream, I can even complete my complete surgery without even having to remove these implants. Coming to the reduction, you see there are 3 types of reduction that we are seeing. The one common thing that we see is the posterior reduction, and this is the anatomic reduction. The one that we don't accept is the negative reduction, where the medial cortex of the proximal fragment is into the canal. It will never unite because it's already in the varus. So body hates varus. Once we are sure that the reduction is obtained, the next important part is getting an entry. I feel this is one of the most important step of your surgery. If you see, what we usually do is first get the geometry of the fracture right. If you can understand the geometry of the fracture, most of your problems are solved. You see here we have traced out a similar kind of fracture where we can see the proximal fragment and the distal fragment. I have to make sure that my purchase has to be into the proximal fragment. There are multiple, you see the first image, do you feel this image is right? It may appear right, but it is not. This is going through the fracture site. That is why we go medial to the fracture so that we get a purchase in the proximal most part. Then that follows the line of the medullary canal. That's when you are going to maintain your reduction. Once you are done with that, the next thing that we do is the play games regarding the position of the helical screws or the helical blade. So as the evolution of the implants and surgical techniques have come a long way, people have been discussing the right position for the helical blades. It initially started with center, then moved on to inferior in the AP and posterior in the lateral, and again it's coming back to the center. So let me say that both the things are right. There's no superiority as such in clinical practice, but biomechanically the inferior screw is more stronger than the center one. Let us see how. You see, this is a primary compressile trabeculae that are going through. They are not going here. They are going through this way. So you have to make sure that your screw has to cross these. Once your screws cross these, the forces that are coming is passed through the helical blade and then transferred through the implant. That is how the bone is getting, the loads are not being borne by the fracture, so it is getting time to heal. When your screw is short and it is ending just almost at the beginning of your trabeculae, there are high chances that the forces are still transmitted through the bone which is fractured. That's how you are going to fail. So whether you put central or you put inferior, this trabecula has to be crossed and get a subchondral purchase. That is the most important thing. Now, so we all know that Baumgartner has given us a theory of the TAD distance. We used to draw a central line through the neck and then calculate the tip apex distance in the AP and in the lateral view. But once I place the screw inferiorly along the calcar, isn't the TAD going to increase? Yes, it is going to increase. That is when Maffoli et al. Came up with a paper where they said that you cannot depend on this because the TAD will increase. These cases are not failing, but why is the TAD increasing? That's when they said that we need to extrapolate the same line and then get this distance, the orange instead of the black one. That is going to be the AP distance of a tip apex distance. And this is known as calcar TAD, cal TAD. Now, the next thing is compression. You have got everything right, you have put your compression screws, but you have yet to compress it. That is when you need to release the traction as much as required for that patient. It depends on each patient, and mind you, if you don't release the traction and compress the fracture and you release the traction after the compression, there is very good chance that you will immediately see the screw backing out a millimeter or so. These cases will lead to screw back out and failure. What are the other tips? So we have discussed regarding PFNA, that is the first generation with the two screws where the one is compressile, the other is anti-rotation. What are the tips for the single helical blade? You see the lateral cortex here? We always expect a controlled collapse for the union, be it a PFNA, PFNA2, DHS or any other implant across the neck. If your lateral if the implant, the helical blade is into the canal, it may not have a controlled collapse because this end may jam at this cortex. Once this happens, there is improper collapse and again may lead to failure. So it is important for you to keep 3 to 4 millimeters of the helical blade outside the lateral cortex. Now coming to the next thing, that is static locking or dynamic locking. There's always a fight regarding this. So most of the people practice static locking in younger generation with the good quality bones and dynamic in osteoporotic bones because they allow more, they have a lot of collapse before they go for union. To be on the safer side, authors suggest, both authors which I have suggested papers, they suggest dynamic is safer compared to the static ones. The next thing is the tip of the nail. You see most of the time the author suggests that we need to keep this nail outside a little, because when you do that, mind you, we are purchasing this, we are getting a purchase from the proximal fragment even from this end. So if you do that, there is no medialization of the shaft. You see here, the nail is gone in and the shaft is medialized because there is no control over here, because this part of the nail is not into the proximal fragment. After this, the final and the most important what I feel is the wedge effect. Serially we'll go and see how a wedge effect occurs. You see, this is a case where it is reduced fracture we are trying to introduce to the tip of the GT. We go in, we do a 13.5 millimeter reamer. You see the fracture opening up and this small chunk breaks off, commonly breaks off, and you are into the fracture side. Once that is done, next is the thing that you start putting your nail. Once the nail goes down, this part keeps enlarging while this part doesn't seem to change much. You see, you still feel that there's a medial continuity. That's the big problem. We do not get to see a lot of this. You see, the fracture has rotated this way. The next thing that we do is we insert the thickest part, that is almost the 13.5 millimeter to 15 millimeters of the proximal part. This further takes it to more varus collapse. When this happens, the next thing that you do is put a helical blade screw. When you put this part is getting compressed, but there is no space for this part to get compressed. The nail is in the way. So you're finally leading to getting a varus collapse. And mind you, to identify such trick, I was just discussing with one of my colleagues, when such thing happens, if your screw blade is going in the superior region instead of going into the middle or inferior region, you should expect that it's a varus collapse. This is one case, a series of cases where this is the wrong entry, just telling, then we change the entry, this is the right entry, and confirming the same thing, rimming, getting the nail inside with the K-wire in situ, again getting the helical screws, both AP lateral, compression screws with the K-wire in situ. Finally, after the compression, we have taken out this, and this is the same, a short video of all the steps with good compression and outcome. And finally, the bonus tip. We get a lot of complicated trochanteric fractures. The one among them is the reverse oblique fractures. We have seen that the trochanteric buttress plate has saved us a lot from the varus collapse, and it has eventually led to the union. You see, this is the immediate post-op and this is a 4 months post-op. This is the difference between using a PFN along with the lateral buttress plate. You don't need to open it much, you just need to send this plate inside, it will take the soft tissue and cover it up. That's all. If you have any questions, I'll take it. Thank you.
Thank you, sir. That was an excellent presentation. And any questions or queries from audience? Okay, then we will move on to the next. That is a case-based discussion regarding comminuted proximal femur fracture with a cement spacer in situ in a polio limb. I would call upon Dr. Arul Prakash to come on stage to have a topic. Dr. Arul Prakash completed his D. Ortho from Madras Medical College, DNB Ortho from Ganga Hospital, and completed his fellowship in joint replacement from Preethi Hospital. Welcome, sir.
Thank you. Respected seniors and dear colleagues, in a case-based discussion, we thought we'll discuss about a rare case, interesting one, which we had last year. So it is about the management of a proximal femur fracture in a polio limb, which had a articulating spacer in situ for quite some time. So this 48-year-old gentleman came to our casualty with a history of RTA, two-wheeler self-fall. He had previous multiple surgeries in his left hip, and his left lower limb was a polio limb, and he was quite obese also. So this was his presenting X-ray. At the time of presentation, you all can see he had a articulating cement spacer with a comminuted proximal femur fracture, a quite narrow diaphyseal femur, and then some eroded part of acetabulum. Going deep into his past history, he had a polio limb since childhood, and until 2016 and 17 there was no other problem like any constitutional symptoms or problem with his gait or day-to-day life. But from then he started to have pain in his left hip, which was worsening, and his gait pattern was also worsening. So he met a doctor outside and got an X-ray done. This was his presenting X-ray to the outside doctor. As we observe closely, he has a hemipelvis hypoplasia with coxa breva, high riding trochanter, eroded acetabulum, some amount of protrusio, and a mortar and pestle appearance in his left hip. So the surgeon thought it to be a arthritis hip and proceeded with a total hip replacement in 2017. And as obvious in a polio limb, to maintain the stability and to account for the amount of valgus and version and abductor weakness, he went in and put a constrained poly. Patient was quite normal for a couple of years, then he started having discharge in his hip. The discharge was on and off, settling with the antibiotics, and it was not subsiding fully. So he had multiple remission episodes. So after waiting for some time, then they decided and went in and planned for a prosthesis exit and debridement. So this was the X-ray which was taken at the time of his infection episode. We all can see multiple eroded acetabulum and the lytic areas around the stem with some amount of periosteal reaction, clearly stating that there has been some chronic infection going on. So in 2022, his implants were removed and articulating cement spacer was put in. At that time, they had taken a biopsy, which they should have done earlier, and found out to be a tuberculous hip. So after that, he was put in on ATT, which he continued for 6 months. And after that, he couldn't continue it because he had optic neuritis. So his ATT was discontinued. With this cement spacer, he was mobile for 2 years, and he was doing his day-to-day life and presented to us after a fall. By receiving him in casualty, his vitals were quite normal with a shortened limb, externally rotated, visible wasting in the muscles and puckered scar, signs of secondary healing and abnormal mobility. So to sum it up, a polio limb who had a THR in 2017, started getting infected in 2019, underwent a cement spacer in 2022, biopsy proven tuberculosis, discontinued treatment because of optic neuritis, and now he has presented to us with a complex fracture with cement spacer in situ. So this is his presenting X-ray, which we had to encounter. Now, how to proceed from here was the biggest question in our mind. So as we all know, replacement being the only option for this. Initially we ruled out infection with lab investigations, which all the blood parameters were quite normal, nothing much to do with that. Then we then we did a CT hip. So the challenges in front of us were an unstable fracture pattern, osteopenia, a very narrow diaphysis distal to the fracture. We were worried about the stability of the processes pertaining to the polio limb, limb length discrepancy, muscle wasting, abductor weakness, which is already there, and the difficult exposure and removal of cement, the articulating cement spacer, which is already there.
Arul,
Yes.
yeah. So at this stage, like what is going on? Can we ask the faculty if they want?
Yes,
like
I was about to ask in next slide. Yeah. So regarding this acetabulum fracture, I think nothing much to discuss. We have seen the cup is very well maintained. Apart from some erosions, we didn't have any defects in need of augments. All we needed was only a large size cup. Now the worrying part is only the stem, which I was about to ask, sir. Now I would request our faculty, Kumar sir, what is your take on how to manage this proximal femur fracture in a scenario where we have a plan for a replacement?
Going through the history, yes, it was primary replacement done, infected, cement spacer, then there was a clinical picture showing that the infection has been settled, the scar was looking healthy. Now the scenario is with a fracture. That is, it is like, assume if you had the prosthesis, if we didn't get infected, the same scenario, if he had a fracture, distal to it, this is like type B, B2, where it will loosen the prosthesis. So now in a regular scenario, the challenge here is, since it's a hypoplastic femur, otherwise everybody knows the bus that just you have to go for a long distal fixing stem. But since you had the opportunity of doing a cement spacer, you would be able to judge the canal size distally. The narrowest one which we have, we start with the distal fitting is a 9 mm. If it is so, you can go ahead with a long stem fixation. Acetabulum side, as long as the column is intact, we are not worried about the subtle erosion. Just with a large column fitting cup, a jumbo cup, you can get away. But now the challenge is, if your canal is narrow, then you can think of a hybrid, that is fixation with, that is fix the fracture, that is reconstruct the canal. And you can do a like an exit, a narrow cemented stem. That is my take on this situation.
Yes.
So this is a very interesting case. This is a case where you look at yourself and you say, there's no good answer. There's only bad things can happen out of it, nothing good. Now, one of the problems is that this guy will not ambulate for a pretty long time because you're still dealing with the infection. You still have to take care. You cannot do any arthroplasty, you cannot do anything as long as you're not sure that the infection is not there. And I totally agree with my colleague here. You need to reconstruct that acetabulum. There's nothing you can do there. So I think with the case like this, I will go slowly. I will first exchange the spacer. I will do some fixation for the shaft fracture. You can take a cement-coated nail, nail the shaft, and do a new spacer for the acetabulum and for the head, and take some samples during that operation and wait a little bit. Give the antibiotics, finish the 6 weeks, do another biopsy. You have to be completely positive that you're infection-free. You cannot do anything over there, because if you go there again and do the arthroplasty, long stem, reconstruction with a jumbo cup for the acetabulum, or even a cage or a spider or whatever, if that gets infected, well, it's game over. You have nothing to do.
Recommendation is two-staged procedure.
Yeah, so you have to take even bone samples during that to make sure that your bone is
How will you fix the fracture, sir? If you are planning for two-staged, you want to put in a plate?
I'm not sure. A plate is an option, but I'm not sure I would want a plate there.
It was
If
quite
out of
OD.
my head, you know, if I have to plan it quickly, I will do something maybe funny. I will take any one of the long nails. It could be a TFNA, it could be any other nail. I will coat it with antibiotic or antibiotic coating, any other coating, and then create a spacer on the screw, on the next screw. So then you have a good construct with the right angle, sitting in the acetabulum with the spacer. You have good fixation for the shaft. You can give him the 6 weeks antibiotics. You can see that you get some callus formation in the fracture. Then go between 6 weeks to 3 months, go in, or even just only by CT do a biopsy, CT guided biopsy, see that you're clean, even aspirate the joint, see that your cultures are clean, and if they are clean, then go for your big reconstruction, take the nail out, do a reconstruction of the acetabulum, do a long stem arthroplasty for the femur, because then you have some structure inside the femur which is already fixated a little bit. It has some callus. It's stable in a way. It's not completely floating.
Thank you, sir. Thank you for your nice inputs. However, size 9 stem, we have a very short stem, sir. I think only 190 stems are available in 9 and 10. If we want a length, then we'll have to go, it starts from 12 in all the stems. So we have fracture up to 12-13 mm here. So it has been little problematic, and moreover he was a huge fellow lying, he was filling the entire structure. So we badly wanted to get him out of the couch as soon as possible, and moreover all our infection parameters were normal, and his previous infection was a tuberculosis. So now literature is telling tuberculosis can be operated. So that's what was going on in our mind, although he doesn't look very septic on presentation. Thank you, sirs. So we proceeded with the surgery. We planned for a total hip replacement straight away, and then after the exposure was a little difficult, after prophylactically circularizing the femur, we went in to ream the femur through the fracture site. So gradually fracture site, through the fracture site, femur was reamed, and then without doubts we got a bigger cup. The previous one was 48. We got a highly poro-coated multi-hole bigger cup with a good press fit in the acetabular component, and held it with screws. And then trial reduction was made, stability was checked. So the interesting part here is we went for a reef stem. It is a new stem it is a stem in debut, which gives us an option to interlock the stem while in the diaphyseal region. So it is a stem with the high modularity. It can be, the version can be changed 360 degree, and once the stem is inserted, we get some amount of rotational stability by adding up 1 or 2 screws in the stem also. And then we can, after putting the stem, since it is a polio limb, we can use a neck in different versions depending on the stability which is required, and then we proceeded with the total hip replacements. And we again went in with a constrained liner because he was already on a constrained liner with very weak abductors, polio limb, revision, multiple surgeries done in the same hip. So his stability was good post-op. This is his immediate post-op. The stem was stabilized, additionally stabilized with multiple circlage wires and cables. So this is his 3 months follow-up. He was put on ATT after surgery and then carefully monitored, and he is doing fine after surgery. This is his 6 months follow-up where all the entire fractures are united. Clinical pictures. And this was the walking video. He is a lawyer, and this was the walking video which we had taken when he came to us by the end of 6 months. And now he is on his, he is yet to come for 1 year follow-up, but he is on his two-wheeler going for work regularly. So these are articles which shows cement spacer has been left into the hip for around even for 10 years. And the average being 1 to 6 years, the average being 2.9 years in certain studies. People have purposefully left cement spacer inside for the want of, they are unable to proceed with the next level surgery whenever there is contraindication. So pertaining to this case, the take-home messages will be the history becomes very important. When we have caught this patient as a TB in day 1, the scenario would have been different. And always rule out infection, do a ESR-CRP in all our THR patient, don't think it is just an arthritis. Keep all the implants, cables, wires ready, because we have to be prepared to expect the unexpected. And plan B, as our faculty told, always be prepared for plan B, abandoning the procedure and converting into 2-stage whenever required. And use of constrained liners play a key role in maintaining the stability of the hip. So to conclude my presentation, fractures around the hip, sometimes even though ORIF is the primary solution for all the fractures around the hip, there are certain indications for each fractures like acetabulum, head, neck, intertrochanter. We have to look into it. Severe comminution, intra-articular comminution associated with the arthritis, some amount of impaction, very old age which needs immediate mobilization. All these cases, arthroplasty is an equally good option for cases where, as our chief used to say, it is a one-stop solution and the patient can be immediately brought out of the bed. But the case selection is very, very important. Thank you, sir.
Thank you, sir. That is a really challenging case. Next, I would like to call upon Dr. Eyal Yaacobi to speak on role of augmentation enhancing fixation in a patient with a poor bone quality, a case-based discussion.
Okay, we're all set. Hi there again. So, this talk was intended to speak about augmentation, basically. And to understand why Johnson & Johnson actually created the option of augmentation, of cement augmentation for hip fractures in their nail system, it's because we're not perfect. It doesn't matter. As much as I think I'm perfect and doing everything, can nail everything, every neck fracture with 10 minutes, spot on, well, it's not always the case. I do mistake, and these mistakes lead us to all these complications. We have the cutouts, we have the malunion, we have the loss of reduction, we have infection and so on, but this is not what they're made for. We're here to talk about mainly the cutouts and the loss of reduction, and basically implant failure. Now, why does it happen? At the beginning, we were teaching everybody it's because we don't use the right tools, we don't use the right nail for the right fracture, and it's true. I don't know if you still use the DHS system or the side plate systems, but they were good only for the stable type of fractures, not for the more complex fracture, especially not when you have lateral wall compromise or you had the medial, posterior medial wall compromise. And you have to recognize these fracture patterns in order to choose how you're going to treat it. Again, know your fracture, then decide how you make it. You cannot treat anything if you don't understand it. And they're pretty easy to understand. If you look on their pictures and you understand what you're looking at, you can understand what's going on. And the one thing I think it's the major point of looking, it's what's happening with the calcar. What's happening with the posterior medial column, sorry, not column, but the wall, the calcar of the femoral neck. Because if this missing, you mean you're dealing with an unstable type of fracture. And when you have an unstable type of fracture and you use the wrong tool, you'll get that eventually, because it will dynamize if you're lucky at the beginning, but then it will start and it will fail and you have this cutout, and then you start to think what I'm going to do with this patient. And it's a mess. It's a mess to take it out, and then it's a mess to revise it. Why it happens? Well, my colleague before me gave a perfect lecture on why it happened. I will go over it quickly again. It's when you don't do it right and the fracture is not stable. Even if you put it in the right place, the fracture will go into dynamization, but then it will start to rotate on the screw, because the dynamization is over, and you'll get the cutout. And that's the result. So recognizing the fracture pattern is crucial for even beginning to talk about anything about hip fractures. The TAD, as my colleague mentioned, it's always, we started to avoid TAD when we started to put the screws more posteriorly and more distally, but it's still, the literature is there that the further you go from TAD, the more your chance for cutout, especially the position where you put the screw. And if you look here, You will see that, like my colleague said, we've gone back to the central point, but if you look posterior, inferior, you got 0 cutouts. You're almost the safest place being down there. It doesn't mean you have to do everybody like that, but if you're down below, you probably do fine, or a good chance you'll do fine. So what do you think about here? Is it good? Is it bad? First look, it looks quite okay. Yeah, but one thing I think is, and a very important note, look at the necklines. If the necklines are not parallel with the screw, with the position of the screw, with the angle of the screw, you will get the failure. You'll get cut out almost positively. This is extremely important point. This screw had to go this direction, this angle, in order to prevent cutout. And, sorry, this thing works slowly. And this is what happens. This is what happened to the patient eventually. He went into cutout. And we'll see later what we've done with him. So we don't live in the past. We have new tools. We have new things to work with. And we have to know how to use them correctly, but we should use them. So let's talk a little bit about our augmentation and about the thing they all brought me here for. The TFNA or the previous PFNA also had this option where we take a cement, we inject it through the screw or through the blade into the osteoporotic bone where you don't have a lot of purges, you don't have a lot of bone quality, and at least lab tests that Johnson made, they showed better strength, better resistance to force, and they showed better resistance to failure in cycles, and they showed less cutouts, at least in the lab. The question is, does it work in the real life? How does it work in real life? So, you know, with the PFNA, there is so many, oh, come on. There's so many cases done, sorry guys. With PFNA, the implementation is very, very easy. You should see it in the OR or in the sew bone to play with it a little bit, but it takes maybe 5 to 10 minutes inside your operation. And the literature tells us that it works very good and reduces significantly the amount of failures. Even if you don't keep all the rules that I taught you before and you made a mistake during the surgery, the augmentation can save you. But this is about the PFNA, and you see there's only 24 papers here. If you search PubMed, you'll find plenty more. But what about the TFNA? Because it's something relatively new, there's less papers, but I think the rules are the same. They only improved the nail when they put the set screw. They prevented the cut-in of the blade. They limited the sliding forces of the blade, the amount of compression you can do, and gave it more stability. A little bit new design with the thickness of the proximal part of the nail. Changed the angle of the neck a little bit, and a few other changes, and they made it a little bit better. But we see that still we have less cutouts with augmentation than without. So let's look a little bit about cases. The first case is a straightforward case. Elderly women. She has a severe osteoporotic, simple fracture, base of neck fracture, an unstable pattern of fracture. And here we're usually afraid that the fracture will rotate even during the implementation of the screw. When you rotate the screw, sometimes the neck rotates with you. You can put the K-wires, you can put everything, but I decided to do a blade with augmentation, put it in a lower point, did the reduction, did the compression, did the augmentation with good reduction, and she went over for good healing. She still did some dynamization on it, but she went on for a very good healing with good results. Another case, mid-neck. We had a lot of argue. I remember with this case, we argued with the arthroplasty guy, should we go to arthroplasty or should we go to fixation? Lucky for me, our age and our diseases around her went towards fixation, and because of the severe osteoporosis, because of the shape of extremely, this is a mid-neck fracture. It's not even a base of neck fracture. It's a mid-neck fracture. So I decided I would go with augmentation. Again, reduction, putting the blade inside, augmented her, and she did some dynamization, shortening of the neck, but still she healed with no cutout, with no complications, and kept on living her few years she still have without pain. Let's move over to complications. So we have this case, another elderly man with a pretty simple type of fracture. It's not a complicated, it's a simple 21A perotontic fracture. This is the same case I showed you before with the angle of the neck, which went over to cutout. And after we had this problem, we wanted to decide, should we arthroplasty him or should we revise him? So he has a good acetabulum. I don't remember exactly why I decided to revise him and not to arthroplast and do replacement for him. But we did the augmentation, and you see no leakage into the joint. We went a little bit further down. It filled up the area of the previous screw, and he went on for a very good healing, being happy. Interesting case, neck fracture, Garden 1 was fixated by the FNS. The new type of fixation from Johnson. I think he had the problem intraoperatively. After he came back, I was looking carefully. I saw something here. I don't know how they done it intraoperatively, but he was released like this. He came back after a week like this. Now what will we do? This is a subtrochanteric, intertrochanteric fracture. You need to nail it, right? You're not going to replace something like that, but still, you have a huge hole. If everyone, and I don't know how many of you did the FNS system, it's a big chunk. You bang into the head and put another screw in it. It means I have a huge hole inside the head already. Now, if I put another blade or another screw inside, I'm not sure it will hold. I don't think it's a good. So we revised them. We took everything out. We reduced them. We nailed them, and we did an augmentation to fill up this space of the previous fixation, and it went on to holding without any cutouts, and straight away started weight bearing. And in the second, when he came back, we saw that he did all the dynamization that we gave him. We did the dynamic screw, distal dynamic screw, went on to healing. I think this is the last case. Oh no, another case. This is a very nice woman. She was operated up north in Israel. She came to my clinic because she didn't know what to do with her over there. She had a lot of pain after the surgery. She couldn't really rehab. And this is the first picture I took in the clinic. And of course, you have pain. You're non-uned, you're deformed, and you have cutout. Your screw is outside, so it's obvious you have a lot of pain. We wanted to do an arthroplasty here initially, but we knew it's a huge operation because she doesn't have a GT, she doesn't have a lesser trochanter. It will be a big reconstruction, and she had a severe cardiac disease. She had an ejection fraction of around 20. All the anesthesiologists told me, please don't operate on her. Leave her like this. Don't bring her to us. So we decided to do something that we can do as quickly as possible. We replaced the nail, put the new nail inside, go as further as we can downstairs. We did have some leakage, just a little bit leakage, but it's not inside the joint, it's outside, so I didn't mind about it. With good fixation. Unfortunately, I don't have pictures post-op. She went back into rehab, and 2 months afterward had a cardiac arrest. But it was extremely unfortunate. But at least her daughter told me that in the rehab she did well, and she was happy. So at least that, her last 2 months, she was happy and could ambulate. That's it, I think. All right, this is the next talk, sorry. So thank you very much. Any questions?
Thank you, sir. That was an excellent session. Sir, any questions?
So what are your
Yeah. Now, how do you decide what is the top line or whatever it is indication to plan for this augmented fixation?
So,
Because all cases, they come
Yeah.
in the old age, osteoporosis is going to be there. How do you decide? What is the...
so we're trying to collect, we're thinking about doing a multi-center study where we just try to decide what is the age that everybody should be augmented. And I know there is a talk about that. Should we augment everybody? Should we augment some of them? Or should we leave it only for certain cases because there is an increased price on it when you use the augmentation? The time is not an issue. The time is 5 minutes, 10 minutes, tops. But the issue is money because the administration will come to you tell you, now the operation cost, you put more cost on the operation, you do 800 cases a year, come on, it's a lot of money, don't do that. So we're trying to decide which cases we do. So you see, I have this small series of revisions, and I started doing more revision cases where even I see that they're on the way to cut out, and even before they cut out, I revise them and do augmentation. So this is for sure I will use the augmentation. The severe osteoporotic, I think the cutout where to use it is when you have elderly patient. I don't know the age. I can tell you 90 years old, but it has nothing to do with it. If you see a patient which is on X-ray, it doesn't have to have a bone scan to prove that. But if you see in Hanske a very bad quality, she has cystic changes in the head, of course oncology cases or stuff like that, they go to augmentation. It will make your life safer. You will worry less from complications. And there's no reports of infections with the augmentation.
Do you screen every case to see for joint leak before you do an augmentation?
No. I know the surgical techniques tells you that you have to inject radio-opaque isotope inside, fluid to see that you have no leakage. But if you... Okay, they're showing me, they're not showing the presentation. If you can put that back, the presentation for a second. Oh, they changed it already. Sorry. Okay, so if they can show you later the tools for the augmentation, the Johnson guys, you will see that there's a pointer. It can go only one side. When you implement the cement, you inject only one side. So you start injecting it and you go slowly, 360 degrees, and you sit under an image intensifier. So you always inject slowly. When you see you reach the limit of the joint, you stop, you change the direction, and you keep on injecting until you see you're reaching almost no, you need the feeling for it not to inject too much and get the leakage, especially if you know that the joint is open. If you know the joint is closed and it's a good head that never been pierced before and you didn't pierce it with a K-wire or anything, then you can just inject and be safe and go all the 360 degrees and it'll be fine. But if you know if the joint is open, then you know more or less the direction. You want to fill it up a little bit and then go to other direction to get the purchase, to get the good hold. Thank you.
The cut-through cases also have
Sorry?
cases, PFN failure cases,
Yeah.
or DHS failure cases. They have the cutout into the joint.
So both cases I saw you, they were relatively, didn't affect the acetabulum. They were on the edge of the acetabulum, they didn't have pain, but you would see that it's on the edge of the acetabulum, it's not really in the dome area where the weight bearing, most of the weight bearing is going on. So that's why I felt that revising them.
The augmentation, how can we be sure that it doesn't spill over into the joint through
So
that?
you do a couple of views. You check. You have two cameras. You do an axial. You do the AP. You can change the angle of both of them a couple of times, and to make sure you're not in the joint. I never had problem. I never saw any cement inside the joint. In these cases, you just have to be careful. You cannot overspill and then go back. The minute you overspill, that's it. So you inject slowly and you take a picture. You inject slowly. You can do it continuous a little bit and make sure that you never reach the edge of the joint, and it'll be safe.
Have you used the Genex putty for this augmentation instead of
Sorry?
cement? Have you used the GeneX putty, the injectable bone graft,
Well,
which sets over a time?
oh, here, so what I was saying before, this we don't need, this is the pusher. You see, there's only one place the cement can come out from. So you know exactly where you're going to inject it. You know exactly which way you're going, so you can direct your cement. I used only the cement that Johnson, because you need it to be fluid cement. Maybe you can add some stuff, but there's no need. You don't want it to be absorbed. There's no meaning in using a biological cement because you don't want it to be absorbed here. You're not trying to create more bone in the head for a 95-year-old patient or a 90-year-old patient. You just want to get a good grip, a good hold, to reduce as much as you can the pain after the surgery, to get her ambulated as fast as possible with no complication. That's your goal. So no absorbable putties or cements. All right? Any other question? The residents are really quiet, I have to say. They don't have any questions. That's it? All right, thank you very much.
Thank you, sir. Next, I would like to call upon Dr. M.J. Krishnakumar, sir, to speak on intertrochanteric fracture, choosing the right implant for right patient. Regarding Dr. M.J. Krishnakumar, sir, he is currently working as a consultant orthopedic surgeon in Bharati Hospital, completed his fellowship in arthroscopy and sports medicine from UK, fellowship in arthroplasty from Bird Hospital, Tirupati, had a publication of 6 papers, presented in several state and national conference. Welcome, sir.
So good afternoon all. Thanks for inviting me as a to Dr. Sivakumar sir and Johnson & Johnson. So here the topic is intertrochanteric fracture, choosing the right implant for the right patients. So before starting the intertrochanteric fracture, we have to classify the fractures based upon the AO classifications, or whether it's stable or unstable fractures, and whether it's on Boyd and Griffin classification, whether several fractures classifications have been done. So AO classifications, it shows that it's a type 3, 1 and A. So there are three types, which is A1, A2 and A3. A1 is a 2-part fractures, A2 is a multifragmentary, and A3 is a reverse oblique fracture. And here's a paper that is Chang. It's published in 2022 based upon the 3D CT images, where the A1, it's a simple 2-part peritrochanteric fractures, and then the A2 is the lesser trochanter fragments, which can be further complicated with different sizes and extent of posterior corneal fractures. And the A3, which is the reverse obliquity or transverse fracture with primary lateral wall ruptures, and A4 is the medial communications with which lacks anteromedial load transmission fracture. So here's the case of 65-year-old woman who works as a farmer, slipped at her home and landed on her right hip and could not able to weight bear immediately after fall, and there's no outstanding health issues with no previous fractures. Here the shows that there's the unstable trochanteric fractures on the right hip, which shows for which we have before going to the procedure. So pre-operatively you have to decide whether it's a stable or unstable fractures. You have to look for the choice of implant and the canal dimensions with the and is there any pre-existing deformities. So here's the post-operative checklist for the intraoperative checklist for the reduction of the fractures to prevent the varus malreductions, the proper positioning of the implant and the patients, and proper rehabilitation. So the main enemies are the osteoporosis and the infections. So here the patients have the proximal femoral nail, which there's no varus malreductions, and the implant is very stable in this case. So the tip apex index already discussed here, which is a strong predictor to the cutout, where the more than 25 mm is the risk of the cutout. And this the other patient shows the 82-year-old man who has the security in the private sectors, had a 3-year fall at his homes, and has no previous fracture, which shows the unstable trochanteric fractures on his left hip for which we have done the proximal femoral nail, where the reduction has been good and the tip extension is less than the 25 mm. And another case shows that the 70-year-old man is a stable trochanteric fracture, which shows on the right hip, for which I have done the dynamic hip screw fixations with a derotational screw. So, and this is the unstable fracture, reverse oblique fractures of the 60-year-old woman who works as a housewife. On his right hip, it shows the reverse oblique fractures, for which I have done the proximal femoral nail. And this other case showing the stable hip fracture of a 55-year-old male who met with an accident, and for which we have done the PFNA with a helical blade. And this is another unstable fracture for which a 41-year male who met with accident, which X-ray shows the unstable trochanteric fracture, for which we have done the proximal femoral nails, which were the tip apex distance shows the less than 25 mm on both AP and lateral views. So the take-home measures is the 3183 fractures do not have a lateral wall to compress against. So DHS, unless used with trochanteric stabilization plate, cannot resist the lateralization of the proximal fragment, which is caused by the deforming force acting on the hip. The cephalomedullary nail provides an effective mechanical block that resists lateralizations of the proximal fragment. So placing the lateral screw helical blade deep and center, less than 25 mm of the tip apex distance in the head will decrease the risk of the cutout. So open reductions with clamps are necessary to achieve normal anatomic reductions. So the value of the fracture classifications lies in the accurate description of the fracture characteristics, reflecting the degree of the injury, guiding the choice of treatment, and helping judge the prognosis and prevent the complications. Thank you. Any questions?
So how do you decide on static or dynamic locking?
How did you decide?
Static and dynamic locking.
So before, once the head screws have been fixed, so after releasing the traction, we can see that whether the compression at the fracture site is reduced or not. So based upon the compression at the fracture site, we will decide whether it is a dynamic screw or a static screws. So the long nails was the patient has had a known breast cancer. So preventing the pre-prosthetic fractures, peri-implant fractures. So we have decided the long nails, sir.
Dr. Eyal, what is your take, Kumar, also one by one? So what do you prefer, the short nail or the long nail?
You know, it's a question I hear all the time. I don't think we have the complete answer for that. When you go long nail, you'll always be safe. It's always safer to do a longer nail. It takes a little bit longer, and it's a bit more challenging, especially with a severely elderly patient where the bowing is a bit increased. It might be more challenging to decide where your entry point for the nail because of the bowing, but it's always safer. Now, most surgeons will prefer the short nails because of the time. It takes 10-15 minutes to nail with a short nail, and you have a guided to the distal locking screw, and it's very easy to implement. And you don't need to ream the shaft. You don't have to do anything. So to balance that, every fracture pattern which is extremely unstable will go beyond 2 to 3 centimeters below the lesser trochanter. I'll go for a long nail. Unless we really want a quick operation for an unstable patient, I'll say, okay, go to the 235, because the new 235 has a right and left design where it takes into consideration the bowing of the femur. If I see anyone with a history of oncology, he will get a long nail. Even if the X-ray is completely fine and you don't see anything, if he has a history of oncology, he will get a long nail. And the severely osteoporotic patient, I would prefer a long nail.
Yeah, in my practice, I use only a 200 nail as a short nail, except in special indications like him, leave about all the metastasis or a periprosthetic fracture. There, I tend to span the entire length of the femur. But the key biomechanical point, as Dr. Yaacobi had explained, if the lesser trochanter has a cortical segment of 2 to 3 centimeters, I would prefer a long nail. The second, the trochanteric patterns with the subtrochanteric extension, I prefer a long nail. Otherwise, all my short nails, I don't go less than 200 because that is the transition zone where you see all your primary metafacial fixing stems, 190, 180. That's the zone of transition. 200, I feel I get a slight diaphacial fit. So most of my patients, I finish off with a short 200 nail, except in these two indications, biomechanical indications. That is of a special mention, that is always. In a metastasis, it's different.
I think so. They are valid points what you both have told, and really we should also consider the curvature in the elderly patient. See, most of these are maybe not very anatomical nails. So most of our elderly population has the bowing of the bones. So sometimes we end up in anterior penetration and all. So we have to be very choosy, and that's a good suggestion. Thank you.
Thank you, sir. Coming to the end of hip session, there is a small modification. We will just go for inauguration before going to knee session. For inauguration, I would like to call upon Dr. Eyal Yaacobi sir, Dr. V.S.V. Kumar sir, Dr. R. Sivakumar sir, Dr. M. Chidambaram sir, Dr. Praglad Kumar Singhi sir, our COO Mr. Zagir sir, Dr. Hema madam on stage for inauguration. We'll have a prayer. Tamil Thavi Valthu. Everyone please stand up. Thank you. Kindly remain stand for anthem. Thank you. Next, I would like to call upon our chairman, sir, Professor Dr. R. Sivakumar, sir, to give the keynote address.
Good afternoon, one and all. Dignitaries over the days and off the days. It's really a very happy afternoon today to have the advanced course on the lower limb extremity fractures sponsored by W. Johnson & Johnson. Even though it's very closer to the state annual conference, I think this CME has attracted a lot of spectators, both online and offline. And what we see is offline people, and many people are watching on the YouTube also. So respected Madam Managing Director Dr. Hema, COO Mr. A.Y. Zahir, our Head of the Department Professor Chidambaram Sir, the invited foreign faculty, Yaacobi and Dr. V.S.V. Kumar from SIMS Hospital, Dr. Praglad, Organizing Secretary, Dr. Krishna Kumar from Madurai, invited faculty, and all other faculties of Preethi Hospital and dear delegates. So it's really a warm day today because we are happy that a person from Israel is here to share his knowledge of what's happening overseas and abroad. And he's a department co-chair in Israel Mir Hospital. And truly we were all surprised and amazed by the work which are being done there. And we'll be able to update what's happening outside also. And you all know pretty well that the knowledge is power and skill is the strength. And this CME definitely will impart more knowledge and at the same time skills also by doing a lot of case discussions and also the workshops if time permits. Definitely it will be very helpful to all the delegates. As a chairman of Preethi Hospital, I would like to say that this hospital is not only entitled to do the cases clinically as a clinical growth. We don't see at the clinical growth alone, but at the same time we also see academically. And we are a PG medical center for 4 DNB courses, orthopedics, emergency medicine, anesthesiology, and diploma in gynecology and obstetrics. So with that, in orthopedics, we try to excel by, we are having 5 seats, primary seats this year. Maybe it's one among a few 5 or 6 centers within India. And our publications are somewhere around 55 publications, peer-reviewed index journals. So we are really happy to be part of all academic programs which are being conducted in Madurai. And thanks to all the delegates at the same time, because since the inauguration is very short and sweet, I think Praglad will be delivering the vote of thanks. But however, with the gratitude, I welcome you all for this wonderful CME. And at the same time, I would also address the Deputy Johnson and Johnson, great guys, Mr. Swaminathan, Mr. Manigandan, who is the head of the academics of India, and Mr. Prabhakaran and Mr. Deepak, who coordinated the entire show within this, and his team, who coordinated the entire show of this day. Thank you very much. Thank you.
Thank you, sir. Next, I would like to call upon all the stage members for lighting of Kuthuvilakku. Thank you. Next is a faculty felicitation. I would like to call upon Dr. R. Sivakumar sir to felicitate Dr. Eyal Yaacobi sir. Eyal Yaacobi sir, please come to stage. Next, Krishna. Next, Krishna Kumar sir. Next, Krishna Kumar sir. Next, I would like to request Dr. Chidambaram sir to felicitate Dr. R. Sivakumar sir. Next, Chidambaram sir to felicitate Praglad Kumar sir. Yes, sir. Next, I would request to felicitate Dr. R. Sivakumar sir to felicitate Dr. T. Vinoth sir. Next, Bharat sir. Dr. Arul Prakash sir. Dr. Pratik sir.
Dr. Subram sir. Dr. Vigneshwar sir. Dr. Prashad sir. Dr. Sanju sir.
Next, Mr. Deepak, Mr. Manikandan, Mr. Prabhakaran from Depu. Please come on stage. Mr. Deepak, Mr. Manikandan, Mr. Prabhakaran. Please. Thank you all. I would like I would like to call Dr. Praglad Kumar sir to give the vote of thanks.
So, good afternoon again. So, I think so. We are having a very good session with the HIP. So, we are also running short of the time. But anyhow, I like to thank the management, Managing Director, Preethi Hospital, Madam, Chairman Sir, Sivakumar Sir, our Head of the Department, Chidambaram Sir, our guest faculty, Dr. Eyal, Yaacobi, Dr. V.S.V. Kumar, Dr. Krishna Kumar, and all the faculty from the Preethi Hospital and the Orthopedic Department for their active participation. So I also thank all the delegates who have come here, as Sir told, after the state conference and trying to share their views and make it more interactive. So I thank also the management of the hospital, Zahir Sir and team, for giving all these amenities and making it so comfortable for us. And I thank Johnson & Johnson for their active participation and the entire team. So I also thank the media people and the AV people for fantastic audiovisual, and also we are going live. So I thank them for this facility. Thank you very much. Enjoy the course.
I would request all to stand up for national anthem. Thank you all. We will have a short tea break, followed by we will have a knee session. Just a short break for 15 minutes and then we will assemble for knee session. Thank you. Thank you, sir. We will proceed with the knee session. First is, I would like to call upon Dr. V.S.V. Kumar, sir, to speak about complex distal femur fracture, how I do it. Dr. V.S.V. Kumar, sir, is a senior consultant and head at trauma and deformity correction osteotomy surgeon at SIMS, SRM Institute of Medical Science, Chennai. Sir is a IOA member, IMA member, TNOA member, and Indian Foot and Ankle Society member. Has attended a lot of workshop and AO master course in Switzerland. Welcome, sir.
Good afternoon. I would like to thank Professor Sivakumar and my good friend Praglad for this invitation, and my team J&J. So, as we are running short of time, My presentation is more of case-based. I'll be taking you through the steps how I do type C fractures. Okay. So as per classification, you know aorta is distal femur is 3-3, A is extra-articular, B is intra-articular, and C intra-articular involving both the condyles. For the youngsters, it is very important always to know the anatomy the anatomy of whichever region you operate and the type of implant you use. So distal femur, trapezoid in shape, you know, and by knowing this, you will know in difficult scenarios, in type A, type B, it is easy. In type C, the position of your plate, so that you avoid the notch, the screw length, you avoid irritation on the medial side, and the primary goal always a realignment, that is to get a good valgus alignment in distal femur. So what are our goals? Avoid varus, which is mechanically friendly for us for healing, anatomic reduction of the joint, and finally a stable fixation so that we allow early mobilization. The challenges nowadays with the type of fractures, elderly population, poor bone quality, distal bone stock, limited bone stock distally for fixation, and the challenges of keeping the elderly ones in protected weight bearing. And we know the distal femur, the non-union rates as per the recent literature up to 22, that is an average of 10 to 20%. So what is in our control? The mechanics, like the working length, the length of the plate, the additional stability with the extra implants, and the alignment. So apart from your x-rays, it is mandatory, like any joint fractures, to do a CT. CT, what to look for, especially in distal femur, as we know 38% of the fractures are having a Hofer component. Always I used to look at this zone. I consider this as a constant fragment over which we reconstruct the condyle. So I call this as a key fragment. So I look for notch comminution and then look for a Hofer component. Deforming forces, yes, so that it helps you to position or to use appropriate tools to counter these forces to help you for reduction. Quads and hamstrings reduce the length. Gastrocnemius takes the condyle into extension and rotation. This is how I position my patient. It is always supine, a radiolucent table. I use a bump under the same side, leg elevated either with the radiolucent triangle, or you can pile a sheet, and opposite side you have your C-arm. Approach, I would prefer the lateral parapetala. This is my workhorse, whether I do a periprosthetic fracture or all of my type C fractures. Hardly nowadays, even for the straightforward, except for the medial ones, I'll show you. So this is the approach. It is a safe approach. No major neurovascular structures, except you will come across the superior genicular artery branch, which you can ligate. Patellar blood supply is not affected. You can see it is the interval between vastus lateralis and the rectus. The moment you enter in, you will see vastus intermedius. You need not split it. You can just erase it along with the rectus on the medial side. So that in some scenarios, some type C fractures, you will see it fully contused, where like your gluteus minimus, you can debride it so that the post-op rehab stiffness is reduced, or you don't induce an injury to the intermedius by using this approach. So another advantage, you have a good exposure to the joint surface, notch, and the medial condyle. So with this exposure, you can reduce the Hofer component. You can do a good articular reconstruction and do with a separate lateral small window, you can do a long spanning. This lateral approach, it's a subvastus, I hardly use. Nowadays I use only for my osteotomies. Medial one, you can see, this is also a subvastus. This side. You can see for type B fractures, where you have to buttress the medial condyle and then plate it, I use this one. So coming to the reduction sequence, primary, like how you heard from Dr. Yaacobi, in acetabulum, start from the joint and go periphery. So if the periphery does not allow you, break it, do similarly, start from the Hofer fragment. So reduce the Hofer fragment, hold it in reduction with couple of wires, or if you're confident of the corridor and available bone, you can even replace your wires with some small fragment screws of 2.7 or 3.5. Then now come on to the intercondylar reduction. Intercondylar reduction, you can use a couple of wires to control the sagittal plane rotation. Then once you control that with the point reduction forceps, you can do an intercondylar reduction, or you can use this big ice tongs for compression. So this reduction, you can maintain it based on your fracture pattern, either with couple of wires, or even you can replace it with screws. Screws should be in the periphery to avoid interference with your plate fixation. So now you got your condyle as a block. That is, the sagittal component is reduced, the Hofer. You got an intercondylar reduction. Now comes you're reducing the condyles to the shaft. These are all important in type C fractures, C2, where you have a metaphyseal comminution. This is the common force, the deforming force. So you have to try to take it into, you have to nullify this extension deformity, you have to take it into flexion. So either by stacking some sheets here, or you can use a shank spin if you have a good bone stock, or a couple of wires, or you can use even your point reduction clamp as a arm to control that distal component. So why I told know your anatomy and the implant which you're using, this is how we normally, that is, you can see the Blumensatt line, the posterior screw hole will be at that line. So once you have an anatomical reduction, even if you use a variable angle plate, there's one center screw which is at 95 degrees. So that falls parallel to the joint. This itself dictates that your coronal plane alignment is normal. So in situations where if the plate is placed in flexion or extension, it affects the coronal and sagittal plane. If the plate is too posterior, when you complete your fixation, you tend to medialize the entire distal femur. You get a hockey stick deformity. Similarly, when it is in external or internal rotation, you have the screws going into the notch or the trochlea. So coming to the examples, this is a A2 type fracture, just to start off with, but if you see this CT, it is an impending one going into a C type fracture. So these situations, these are cases which now I routinely do nailing, but just for knowing the reduction sequence. So usually you will see a metaphyseal comminution, a void. So here the importance is how to maintain the alignment in both the views, coronal and sagittal, and go on to your fixation. Look, if you take it anatomically, you will have a big void here. So you're trying to do a non-anatomical reduction, maintaining valgus, you're trying to intrinsically take the lateral cortex in. Similarly, the anterior void, try to take your posterior cortex in, take it into extension. You can stabilize it with wires. Then your sequence of fixation, whether it is a single plate or a dual plate fixation. So this was a post-op, 3 months, and this was her function. So now coming to the C-type fracture, C1, that is an intra-articular one without comminution. So usually you will see in C fractures, you will see a anterior metaphyseal void. You need not worry about it. As I told you, these are the two wires controlling the condyles, the sagittal plane reduction. Once you get the intercondylar reduction, you can hold it with these wires or replace it with screws periphery. As long as you have this lateral and medial column or the pillar intact, you need not worry about this anterior void. You can go on to your fixation. So this is that anterior void with the soft tissue which has the fragment put back in place. The same radiological description. So you have both your pillars intact. This is a sagittal view. You reduce it, you hold the intercondylar reduction with wires, then go on to your plating. So the key here is trying to first get an intrinsic stability, then trying to fix it with the coronal and sagittal plane alignment. So this was a post-op, this was at 3 months, 10 months, and this is a function. So now the next one, C2. C2, it's an intercondylar fracture with metaphyseal comminution. The same reduction sequence. So you can see it is actually a C3, but since I wanted this as a description for the metaphyseal comminution, you can see with this exposure, you have a good access to the notch, the condyle, the same reduction sequence once you get the intercondylar alignment. Now, these are the scenarios I was telling you should not go wrong in terms of your coronal or sagittal plane malalignment. So here I had used fibula stud graft since it was a large void. So finally you can see a good valgus in AP, and you can see the lateral coronal alignment. If most of the scenarios, if this mechanics is right, which is because nowadays the bone quality is poor and the fracture pattern, that is limited bone stock distally for the screws to hold, this plays a key role to prevent biomechanical failure. So this was at 5 months, this is at 8 months. So he has come only close to 70 degrees. I usually give my patients 1 year duration to see whether they go beyond 90. If they don't go, I offer them a quadriceps plasty after 1 year. So this is another case, C3, intercondylar metaphyseal comminution with a quadriceps rupture. So once you have this exposure, you can tailor your entry into the fracture based on the soft tissue injury. So look into the CT, look for the notch, the key fragment. So now you know what sequence you want to start. So as I told you, those 2 wires controlling the sagittal plane, intercondylar reduction. Now you have put back, you have lateral column, but you don't have medial column. So these are the fractures which may fail if you depend only on one plate, fail into varus. So the pull-out strength. See, you see that anterior void, how this anterior void is reduced. See the posterior cortex. This is a thick bone like your calcar in your proximal femur. So you can reduce this void by doing a slight non-anatomic reduction. You can put it into it, you get an intrinsic stability, and you are able to reduce this anterior void also. So now you go on to, this acts just as a medial pillar. There's a big void here, only lateral there is continuity. This is only to maintain this valgus till you complete your fixation. So after the fixation, can you see the defect here in the medial column? So shape match tricortical graft was taken, that was wedged in. That was post the quadriceps repair. This is his initial post-op. Good, you can see the good alignment in both the views. This was the incorporation, the consolidation of the graft, and that is his function. So now the next pattern of C3, intercondylar comminution, metaphyseal comminution. This was a compound one, but it was an in-out, no contamination. So day 1 I had planned for a reconstruction. Look at the notch, the key elements to start off with your sequence. So the exposure, as even in such bad fractures here, you're able to, this is intermediate, this is what I was telling you. So when you go in the interval, either it is injured or you can see the muscle in full. You can take it off to the medial side along with the rectus without splitting this. So same sequence of reduction, intercondylar reduction done. Look at the image here. So why I told you this is an important key element. You can make your condyles in proper position even when you have a defect anteriorly. So now this was the template which was ready. That is lateral column, length, alignment restored, intercondylar block ready. But I have a huge medial pillar defect. So I had taken a large fibula stud graft. I had augmented. Can you see this dotted lines indicating the fibula stud graft? That is the pseudo medial column, medial pillar. Then once this construct is ready, this reduction in both the views is ready, then the sequence is going to be the same. So that was at 9 months. This was at 2 years. Complete, you can see the hypertrophy of the fibula stud graft, and this was a function. So This is slightly a different sequence which I would prefer for rheumatoid patients, patients with poor bone stock, or a post-polio patient where the bone quality is, he had a bilateral C3, but let me show you the sequence of only one side. First, the same exposure, assess the number of fragments, then try to puzzle match, reposition. So all first reposition with wires in any corridor, then start replacing it so that it doesn't come in the way of your fixation. So then once that condyle is reshaped, next is alignment, coronal and sagittal. Assess the amount of bone loss. So based on the bone loss, these are all tricortical wedge supporting the pillars. So primary itself, bone graft, trying to recreate. Here if you notice, I place both the columns, the condyle is wedged between these two plates. So I do an elastic fixation distally. Start off with your proximal fixation. A single cortical screw through a lateral plate, medial plate. Don't tighten it fully. Then now you are trying to wedge the condyle between these two pillars. These pillars are the plates. Use these two reduction clamps. These are all the big reduction clamps to compress both the plates. That is, the condyle is wedged between these plates. Once this is wedged, then complete your cortical fixation proximally, then the sequence of fixation is same. So this was his immediate post-op. That was at 5 months. That was his function. The left was, he had a power of 3/5. Right was a flabby one. So it was only an passive movement. So these are the various ways in complex situations with bone defects, how you try to address the approach, the fragments. Now with more volumes of periprosthetic fracture to add on to stability, plate nail combo, other than dual plates, plate nail combo is a fantastic tool to increase your stability. That was a C1 type of fracture, the same approach, sequence, reduction, all. So once you have a thick wire or screw out of your nail holding the intercondylar reduction, then you have your nail inside. This is a small reduction tool just to maintain the alignment. Then once the nail is in, then you can complete your plate fixation. So that was it. At 1.5 years, that was his function. So in elderly, in floating knee, you can consider this also as an option. That is either nailing for both your C-type fractures with metafacial comminution. This was at 1 year follow-up. This was his function. So in elderly patient, it is a powerful tool with limited bone stock, small reduction plate with a nail inside plate. You can see at 3 months itself, you can see this posteromedial bridge of callus you see in these patients. This is a 95-year-old gentleman. So the take-home message is know your bony anatomy, know your implant which you are going to play with. Alignment is the key for any low limb fractures because biomechanics is favorable. You saw a wonderful talk on intertrochanteric fractures. It's all first the reduction, the alignment, then the sequence of your fixation, because rather than what type of implant, these factors, the intrinsic stability, the alignment, all favors you in terms of not only healing, but more you have chances of, less chances or load to failure for biomechanics. So this is my take-home message. Thanks once again for this invitation.
Thank you, sir. We will have discussion at the end of this session. Thank you. Next, I would like to call upon our chairman, sir, Professor Dr. R. Sivakumar, sir, to have a talk on intra-articular fracture non-union around knee. Sir, Dr. R. Sivakumar, sir, is a chief orthopedic consultant, trauma and orthopedics at Preethi Hospital. He is a former professor and orthopedics unit head from Madurai Medical College, past president of TNOA, present vice president of OASIS. And he had a publication of 29 articles in international and national journals and his academic career is very big. He had invited as a faculty in state, national and international conferences, and a PG examiner in MS and DNB ortho candidates. Welcome, sir.
Thank you. So this is this is a presentation out of the box, not in the acute fractures, but in cases where they come in a delayed way, and how to address these cases. Of course, I'm very happy that Kumar has addressed the Hoffa's fracture and the management to a little extent. Maybe some points may be very useful here. So whenever you see a case, a knee patient with old injury which has been fixed or not fixed, they present with stiff and arthritic changes. So that's the most common presentation. And when we see them, when we see something is not there, not united, then we are really baffled. So what to do? Is it really going to do good for the patient, or is it going to be a permanent disability with stiffness? So that's the major problem. So whatever it is, any intra-articular fracture, we better go for a stable fixation, and biological enhancement should be done. So whenever you see a non-union intra-articularly, who will be the culprit? Either it's an inadequate fixation, or a failure of biology, or some infection which is going on. And the fourth one which I which I wanted to point out here will be the synovium. As you see in intracapsular fracture neck of femurs, the synovial fluid will wash away the hematoma, and some amount of non-union can come in intra-articular fractures of the knee. So that's one of the important points which I wanted to stress here, which may not be much in the books. So we have to evaluate thoroughly with the history and the previous surgery, then the wound healing following the previous surgery, and blood workup has to be done, and X-ray and CT MRI, as Kumar was showing. So non-unions of the distal femur, then I'll go to the patella, and then the tibia, and that will be completing my speech. So Letoner classification, I think till about 1970s, there was no more focus on the Hoffa's fracture, and after 1970 only the Hoffa's fracture picked up, and many cases they were found that they go for a non-union, or improper planning also will lead on to non-union and avian of the fragment. So I think these three things, 1, 3, they have a good prognosis, whereas 2, they don't have a good prognosis. So most of the time they can go for avian or a non-union or a poor fixation. So these are the things which should come in your mind whenever you see a isolated Hoffa's fracture. And I'll go through some case examples. This is a 23-year-old female. That's the CT of the patient. The 23-year-old female, pointer okay. With operated elsewhere, with pain and stiffness, and surgical scar present over the anterior aspect. It's okay. So tenderness present over the lateral condyle of the femur with the FFD of 20 degrees, and this is the range of motion up to around 40 degrees only present. So what went wrong? What is missing? Is a young girl, and that too she is a doctor by occupation. Okay. So what went wrong here? It has been fixed. An anteroposterior screw has been done for these patients, and here you find a huge void, and there is a definite evidence of non-union. And fracture reduction has been done, but still resolved since fracture stability is at stake now, and there is an inadequate fixation. So what you want to know, what should be done is, these fractures need absolute stability, and you must know when and where the plate and screws have to be combined for Hoffa's fracture. So most of the time Hoffa's fracture, you have different types of fixation: anteroposterior screws, postero-anterior screws, 6.5 mm screws, 3.5 mm screws, even Kumar was telling 2.7 mm screws, long screws. So biomechanically that doesn't make any much difference. But however, you should know which cases where you have to plan for plate and screw fixation, and that can go wrong also. So if you are not going to do with that, it can go wrong. So what I did for this patient is, we went inside, removed the screws and freshened the surfaces and went for a screw and plate construct. So this was the procedure done, and here this is the patient's flexion. So any incongruency in reduction and any non-union can end up in a major disaster, and you may have to better undo it, and you may have to proceed with this. So next, in another case, a 54 male, see, you'll be able to see type 3 Hoffa's fracture. Type 1 Hoffa's fracture, operated outside, came with difficulty in walking with restricted ROM and a stiff knee. So you'll be able to see the impinging K-wires, and at the same time there are the screw heads which are also impinging. So what is missing? Again, fracture union is at stake, implant irritation, and joint mechanics are disturbed, and there is an additional resorption of the fracture ends. So what should be done? It needs absolute stability, and screws and plates were needed. Need of graft is required to maintain the height of the condyle. So how to address this? So we have done bone grafting with the removal of all the fibrotic tissue, and then gone for a neutralization plate. So this is what we have done, and the patient is doing well. Another case, a 2 years old distal femur, you will be able to see a articular step in the non-articular portion. So this portion. So here there is a step here, but patient was complaining of pain, difficulty in walking, and he came to us. MRI was done, and CT. You will be able to see the cleft here in the in between the condyles. So this was an interesting case. Maybe 2 or 3 cases we have come across the entire span of my practice. But what I wanted to tell here is, the synovium goes inside, and the synovial tissue also proliferates, and this ends up in a constant pain source whenever the patient comes after a fracture, and you must be able to identify that. And this patient was done rawing of the surface, and then we went for a fixation, and patient did well. Again, he had an ACL tear, and this patient was done an ACL reconstruction. So the possibility of the ACL injury during my procedure also could be there when we address the non-union. So that's one more point which I wanted to commit here, and this is 2 years, patient is doing well. A 25-year-old male with, see, this is the X-ray, and this patient comes, when the patient comes with the pain and difficulty in walking, you will be, even though the range of motion is 0 to 20 degrees, there is a minimal lateral subluxation. It's better you go for a CT. What seems to be united in the cortex in the metaphyseal region, there is no union at all. See, you will be able to see here. There is no union at all except for a cortical union here. So you must identify that. It's better you go and revise it, and this patient has done well with after revision. Revision means again procedures for non-union, and a long plate has been done. So in Hoffa's fracture, what I would like to insist is, there are even in the acute situation scenarios, if there is osteoporosis, if there is a metaphyseal spike along with the Hoffa's element, and if they are multifragmentary, it's better to go for a plate and screw fixation rather than a screw fixation alone. That's one thing which I wanted to tell. This is another case. In the patella, the patient had a fall from a bike, and the patient had tenderness over the patella. So So this was the CT finding. In the X-ray, you are likely to miss it, except if you see closely, there is a sagittal split of the patella. So here you will be able to see that. So there is no harm in either doing a CT or MRI. MRI is much preferable because they also give the ligamentous status. And the patient had a medial meniscal injury, which we didn't address. The patient was addressed using the interfragmentary screws and a small faciomaxillary plate. The patient did well, and this is the post-op follow-up. So the algorithm, if at all, if a patellar non-union, if you see a patellar non-union, you go with the clinical examination. If the patient is a low demand patient, you go with the non-operative methods. If your patient is a high demand patient, you, based on the fracture type, if they are amenable to internal fixation, go for an internal fixation with bone grafting. If there is severe chondromalacia, or if the fixation is not possible, it's better to go for either a partial patelectomy or a complete patelectomy. So non-unions in the tibia are very less. Non-union in the intra-articular non-union in the tibia are very less. Almost you will not be able to see one case in 10 years of your lifetime, because the metaphyseal blood supply is very high, and the non-union is highly uncommon. But some or other you encounter in some patients where there are some open injuries, and you will be able to see some cases. This case was operated elsewhere, fixator has been done, and intra-articular fixation was done, and we did a open reduction and internal fixation with dual plating in titanium LCP plate and screws, and autologous iliacrus grafting was done. So 3 months post-op, even though you find the slope is not perfect, somehow or other we managed to do with the bone reconstruction, and the dual plating was done. Patient has done well. So in non-union of the proximal tibia, there is very few literature, and the management is not standard, and it should be individualized based on the patient's condition. So the causes of non-union, the present condition of the knee joint, range of motion and at the knee joint, and the age of the patient should be considered. Based on that, if the patient is young and if the demand is more, there is no harm in you planning arthrodesis. And if the patient is elderly, if the demand is that is whatever is there, based on that you can plan for arthroplasty. So this is the take-home message. So the intra-articular non-unions are different from diaphyseal non-unions. So perfect reduction of the articular surface is mandatory. Primary anatomical reduction and stable fixation gives excellent outcome. Careful soft tissue handling and minimal bone devitalization, and sometimes bone grafting may be needed. Stability, synovium or surgeon can be the culprit. So triple S can be the culprit, and intra-articular non-union needs more expertise in management. They present with instability, stiffness, plus or minus arthritic changes, and thorough preoperative planning is mandatory before you embark on any intra-articular non-union of the knee joint. Thank you very much. Thank you.
Thank you, sir. That was a great presentation. Next, I would like to call upon Dr. Praglad Kumar Singhi, sir, to speak about floating knee injuries and CCC classification. Dr. Praglad Kumar Singhi, sir, completed his DNB from Dinanand Mangetkar Hospital, and he did his AO Trauma Fellowship from USA. Sir is a senior consultant in the unit of trauma, arthroscopy and sport injury. He is a EC member in IOA, IAS and TNOA, section editor of IJO, has published more than 30 articles in national and international journal. Sir holds the Silver Jubilee Oration Award in IOCON 2024. Please come, sir.
So we have gone through the hip and now through the knee. We have seen complex distal femur fractures, non-unions. So I would like to share our experience on floating knee injuries. So we all have these high velocity trauma kind of cases where we come across, and so we all know that floating knee injury is a more complex injury, and It was the term coined by Blake and McBride, and Ratnam has told that it is definitely something beyond the fracture in femur and tibia. It is much more than what meets the eye. So it is defined as a flail knee joint which arises because of the fracture of the femur and tibia, and these are most often high velocity injuries, and we all know that they have a very significant mortality, and there is almost 10% mortality of these kind of injuries, and they come with the mangled situations in several cases. The fat embolism, the compartment syndrome, these are again not uncommon. The most important is the severe head injury, chest injury. Many of these patients fail to reach the hospitals. So we don't know how much percent of people fail to reach the hospital, but definitely in such high velocity injuries, that possibility is also there. And they say that around 70% of these injuries are open fractures, so we have to be very careful. So it is also possible that we miss the associated injuries in these kind of situations. So we all focus on the fracture pattern, but the ligament injury is always missed, and it is around 20% fractures which have been missed associated with ligament injuries. We all know these are the standard classifications we follow. The Fraser's classification, the Blake and McBride the Fraser's is the one we most commonly follow. The Blake and McBride realized the importance of the hip and the ankle, which is missed in the Fraser, and the let also try to include the open injuries in their classification because they are the one which influence the outcome. So if you see, this is Fraser type 1 fracture, but the problem here is the open injuries which is not taken into consideration in these fractures, and also the fractures around the foot and ankle. So this is type 1 Fraser, both diaphyseal fracture, but the prognosis would be different because of the combination of both the diaphyses. And also if you see the patella fracture, the patella fracture is also most common association in these kind of injuries. So again, if you see, these are the floating knee injuries. It is type 2 Fraser, but what is missed is the neurovascular injury. So the neurovascular injury is again a very common association we have to keep in mind. As I also told, the ligamentous injury should also be kept in mind. So these are certain things which are often overlooked in these floating knee injuries. So this again, bilateral floating knee injury, this is the typical dashboard kind of injury where this gentleman had a this gentleman had a fracture of acetabulum. So this gentleman had fracture of acetabulum. You can see there is a central dislocation of the hip, and also there is a PCL avulsion. This is typically seen in a dashboard kind of injuries. So this tan row
come with a modified classification for patella, which was included and published in Injury Journal. This is a review article by Nishant et al., who have told that there are these fractures which has to be taken into consideration when we want to prognosticate a floating knee injury. So what is not considered in these fractures is the open injuries, the grade of combination, the degree of combination, the intra-articular things, and the comorbidities, and also the osteoligamentous disruption. So we try to conglomerate all these things. We clubbed all the three Frasers, Blake and McBride, the Gustilo Anderson, the Evo classification for combination, the injury severity score, and then the modifiers. We knew that these three modifiers are the very important component which may prognosticate the outcome. That is the extensor mechanism disruption, that is the patella or the quadriceps injury, the osteoligamentous disruption, and the periarticular fractures around the hip and ankle. And in 2021, we published this paper in Injury Journal, where we have come up with a comprehensive conglomerated classification. So the conglomerated classification, we have 4 types. The type 1 is the diaphyseal fracture.
Without any comminution, The type 2 is again diaphyseal fracture with comminution at the diaphysis, and type 3 is a metaphyseal at either femur or tibia, which is a simple articular type, or it can be partial articular or simple articular without any comminution. And type 4 is the metaphyseal type, which is more complex and comminuted. So now we have 4 types which has both diaphyseal and metaphyseal involvement. And now we also brought in the 3 subtypes. The subtypes is A, which is closed or grade 1-2 injury, where most of these undergo a complete closed management, whereas the type B is, subtype B is the grade 3A and B, where you have to do some kind of plastic procedures, do a DCO, and then later do a definitive procedures. So type C is one with the neurovascular involvement. So we know that here the patient is going to stay with you for a longer time. You need to have a multiple procedures. The prognosis can be identified and inform the patient at the very beginning. So modifiers are M1 extensor. So M2 is a osteoligamental disruption, and M3 is a periarticular fracture around the hip. So basically, this conglomerated comprehensive classification has 4 types, 3 subtypes, and 3 modifiers. So when you tell it is a type 1 A with M1, we know that this was a closed injury with a diaphyseal fracture with a patella fracture. So this is better, has a prognostication in mind. So we all know any treatment method will depend on the fracture pattern, location, soft tissue injury. The most important is the availability of the resources. Multidisciplinary approach is very important. The injury severity score has to be kept because all these are high velocity injuries, and it is very important. We take into consideration only the score patients which are less than 16. So when they are minor or moderate kind of injury severity score. The severe and very severe, most often they end up in become a unstable situation. So based on this, we do follow this treatment protocol. So whether the patient is stable or borderline or unstable, and based on the type A, B, C, they go for either early total care or they go for a damage control fixation. And the modifiers are identified and addressed during this. So we recently coming up with this publication where we analyzed 230 cases of floating knee injuries, of which 201 were included in this study, and the road traffic accident was majority of the cases, and if you see the youth is the one which is most commonly affected. And this was the pattern of associated injuries. If you see again, the significant number of patients had patella and knee ligament instability, so which is most often missed and can be the most common cause of either knee stiffness or knee instability in spite of an excellent management. So this was the distribution of cases in our series where we had majority type 4. So again, it is high velocity injuries where they usually have a very poor prognosis. So again, this was the pattern of modifiers. If you see 23% had patella extensor mechanism disruption, 16% had osteoligamental disruption, which we were able to identify during the index procedure and address. So hip and ankle fractures around 18%. So this is again the pattern of open injuries. So we also tried to assess the number of days of hospitalization of these cases, and we were able to prognosticate that when they are in early types and without much subtypes, they have a better prognosis. And also the number of procedures each patient underwent, we also documented, and whether they have undergone early total care or DCO. So the neurovascular injury is very important. We had several around cases with neurovascular injury, and they also ended up in amputation. For example, this kind of ghastly injury when you come across, the life saving becomes the most important, and we have to do amputation so that these patients can get back to rehab earlier. So these are, though they are young male, but the salvage is very difficult in such cases, and they life saving becomes more prior than the limb saving. So the road traffic, as I told, was the most common cause. Again, these 3 guys going together in a single bike, all the 3 had floating knee injuries. And if you see, this was the fractures they had,
and all three underwent definitive fixation, and all three had an excellent outcome in spite of these complex scenarios. So this is again a very young chap, bone loss, both diaphyseal at femur and tibia, and multiple procedures, bone transport, and he has this kind of outcome at 1 year follow-up. So this young chap, again vascular injury, vascular repair was done, and he presented to us, though he had a PCL injury at that beginning, we were not able to fix because of the vascular thing. He presented with instability later on, and we did an ACL, PCL, and PLC reconstruction for him. So we were able to identify these ligamentous injury pattern, and this is the kind of association in these floating knee injuries. They have a lot number of multi-ligament situations. So identifying them will help you to get a very better prognosis. This is again our publication in Indian Journal of Orthopedics, where we analyze the knee instability following fractures around the knee joint, the diagnostic dilemma and management challenges. So this is again a very ghastly young male who presented with a shattered knee, and this was contaminated. We published this paper by soaking this extruded condyle into the betaine codeine iodine, and this is at 9 years follow-up. We were amazed. We just asked him to share the follow-up, and he is doing all kind of work as if he doesn't had any kind of complex injury like this before. So this is another gentleman. Here we have been, patella has been a savior for us in several situations. We have used the patellar articular surface to reconstruct such scenario, and this is again 8 years follow-up. This gentleman is doing all his activities in spite of this complex fracture, able to sit cross-legged. So this is again huge 120 kg chap, bilateral injuries, right? With a vascular injury, he had a knee dislocation. He has undergone at least 10 procedures, and we are very happy that he has gone back to his passion of doing the gym. So he is happy, and we are able to have this. So this is very bad. The people had suggested amputation for him. So he was a young chap, just 19 years old. We tried to salvage. We did after debridement, and we could see that there was no lateral condyle for him, and affordability was an issue for allograft. So we did a Merli D Abuji procedure where we transferred the patella. So the patella has been savior for us on many occasions, and this patient is at 18 months follow-up. He is able to do all kind of activities, climbing the stairs, and this is again loss of entire lateral femoral condyle here. So we did this fixation. This was, I think, so around 10 years before. So we told him, we suggested orthodesis, but he wanted some kind of movement. But after 2 years, he came to us and accepted orthodesis. And this is almost now 7 years. He has adapted to this kind of lifestyle. So complications are part and parcel of these injuries. We have to accept them. Though with this kind of management, we are able to keep them at a very minimum level. But if you know the classification, we will be at least able to identify these instabilities and know which case is going to end up with stiffness. So this is a recent article which has quoted our publications in the injury journal. So to sum up, these are high velocity injuries. So we have to consider all the factors which we discussed before, which are beyond fracture and femur and tibia. So CCC classification, that is conglomerated comprehensive classification, is a useful tool to prognosticate the outcome. Identifying and addressing the modifiers will minimize the complications and also helps in identifying concomitant ligamentous injuries, which will have an excellent outcome if you manage them. Thank you.
Thank you, sir. That was an amazing presentation. Next, I would like to call upon Dr. Yaacobi, sir, regarding a management of complex distal femur fractures and about RFNA and innovation to tackle challenges.
Question to Kumar sir.
Sir, in most of your cases with the nail plate concept, we are able to see that nail was much more longer than the plate, and most of the nail has not lost the proximity. Whether there is any specific reason, or most cases we see nail will be a bit shorter, they will stick and long plate. What's your opinion regarding this?
If it's a periprosthetic, I do the reverse. It's a long spanning plate and a short nail for stability. But in a fractured situation, based on if there's no proximal implant, I use a nail. In terms of literature, if you ask me, if you're able to get the distal screw through the nail, you need not lock proximally. If not, but actually it adds to stability, provided you don't have a isthmal diaphyseal fixation. If you really get a diaphyseal fixation of the nail, you need not worry about rotational stability because the plate offers you the rotational stability. So you tailor it based on your case situation.
Snug fitting nail, good
Yeah.
hold proximally, and a distal locking through the nail.
Yes.
Minimum 2 screws.
Yeah.
Holds good. Thank you, sir. Thank you.
So another thing, like we have seen you have done a lot of bone grafting, fibula bone grafting. So what is your indication when you do a pre-operative plan? So when do you think that, okay, I'm going to do a fibula crust? Because you mentioned iliac crust, fibula crust. So how do you plan that?
All my type C3 fractures, patient goes to the theatre with the consent for bone grafting, be it iliac crust or fibula stud graft. And like for my proximal humerus fractures, when it's a 3-part or 4-part, I have reverse on table like that. I go with the prosthesis on table. So now the challenge these days is, like it was a fantastic presentation of the floating knee. The challenge nowadays is the pattern of injury. Most of the classification don't describe what we see in our day-to-day practice. So the availability of bone for the fixation. So you, in spite of doing so much preoperative plan of plan A, plan B with the CT preoperatively, you will see a lot of intra surprises. You're not able to really make the puzzle. But what over years we have come across, when you leave a defect, though it is anatomically reduced in both the planes, you leave a defect and come back, the load to failure chances are less. But when you don't leave a defect, you have an intrinsic stability with bone contact or pillar reconstruction where the bone graft plays a role. The load to failure is more. These play an important role in the elderly population, rheumatoid, where the bone stock is poor, and it is a challenge for keeping these patients non-weight bearing.
So what we have seen, like doing everything in a single go, doing a bone graft, doing a dual plating. Most of, in our situation, what we see are, these are either grade 1, grade 2, grade 3 open injuries, even because of the high velocity when they come in the young injuries. Do you follow this in till grade open injuries also, or do you refrain from bone grafting in?
If it's a proximal tibia or a pylon.
We are taking about femur.
If it's a proximal tibia or pylon, mine is always a 2-stage.
Okay.
If it's a distal femur, where I'm not worried about soft tissue, I'm worried only about contamination. If I see macroscopic contamination, I debride, span, later go in. If I don't see a macroscopic contamination, I do a primary fixation. Sometimes, in spite of my debridement, primary fixation, even though I don't see contamination, I may leave antibiotic stimulant in place. So mine is, in terms of femur, early total care.
So because femur has lot of muscular, so that is the reason there is a good vascularity. Yes. And you have chances to escape. But that cannot be happening in plafond and even some
proximal tibias. Yes.
QB, what is your experience about fibula stud graft and primary bone grafting? Mic is on, sir.
No, it's fine. So you don't do vascularized fibula, right? No. So I have to say I never used the fibula graft for distal ends. The only place I maybe done it once was proximal humerus. I never did it for femur or tibias. I did do it for tibias, but for bone loss in the mid shaft, and then I always do it vascularized. Always bring my plastic surgeon, my microvascular surgeon, and many times I have one case where we did bony cutaneal flap, where we took the fibula with the cutaneus and the muscle above, vascular flap, moved it all because it corrected our soft tissue loss and our bone loss all together in one shot. And it worked amazing. I think fibula graft are a very good tool. I have to say, amazing cases. You know, it's amazing, and it's a talk nobody does, how the mechanism of injuries changes from one country to the other. Because, you know, here you have a lot of probably motorcycle accidents and car accidents, and a lot of cars are old cars in your road, so they don't have the knee airbags like we do in Israel. So I don't see these patterns anymore, you know. They're quite rare. I deal more with ballistic injuries. I get distal femur and proximal tibia injuries from ballistic or from work-related, fall from heights and stuff like that. Sometimes pedestrian accidents and so on, where you get severe injuries, but nothing like this. This is amazing. The work you do, it's unbelievable. Which plate do you use for medial support, the medial plate?
Earlier I used to use the proximal humerus plate. Sometimes the proximal tibia opposite side I reverse and use. Nowadays I get a lot of our Indian makes medial plate, which contours well.
Yeah, so same thing. I used the couple of times I did it, I used the proximal tibia plate, just the other side, and flip it. It works pretty good. Sometimes just a recon plate, you curve it, sometimes it does even a better job. Yeah, the new distal tibia design can work. I never tried it. Maybe I'll try it next time. It's so nice.
When I was there in USA, Professor Raymond White, so instead of putting a fibula graft, he used to put a DCP plate. He used to put and I have done one similar case where he puts the nail plate inside, plate outside, and try to put the screws through the holes, matching them. So that is one way of just maintaining.
That is a fantastic, very old technique which has over time given away, not picked up by the younger ones. Actually, this biomechanics of intramedullary with plate, those were endosteal platings. That were phenomenal stability, but we are not incorporating.
So I think that the nail plate combo in proximal tibia and distal femur and other places are probably going to be the working horse in the next few years, until maybe we'll find something better or find a solution. And actually it goes together with my next talk for the new design of the femoral nail system, the RFN, with its side plate. So we're going to look at the new design of the nail, the new design of the screws, and the meaning of why we added the side plate, and why we need it, because we've been nailing for a very long time the distal femur, but we know that when we have a distal femur, extremely distal femur fracture, our current nails didn't really hold. They didn't really do a good job only as a nail. You cannot do a MIPO operation. You cannot do a very minimal invasive operation and hope that they will capture the intra-articular, all these multi-fragment fractures. When we have the periprosthetic fractures, the current nails didn't really have enough purchase with the screws to hold this, and you have to take in account the size that you have here in the boxes. Lucky for us, trauma surgeons, that most of the arthroplastic surgeons use today the CR prosthesis, so they at least give us the chance to nail it. Come on. So our working horse was the plating, the side plate, the long side plate, the VA. Today we use the VA condylar plate, which is a very good system, I think, very comfortable to use. But it's not without problems. It has its problem with the severely extension to the diaphyseal part. You need a very long plate. You cannot, you have to open, you have to do, it's very hard to do a MIPO operation with these plates. You could, but it's, today the attachment is more proximately, so it's not really a MIPO. I told someone yesterday, MIPO in Hebrew, it's from here. So we always make fun that MIPO is from here to here. So this is your MIPO cut, from here to here. But it doesn't really a MIPO operation. And when we try to do the periprosthetic with the straight nails, we had always a problem with recurvatum, and we always saw this varus. They did heal, but we saw many times this varus malformation in the plate. Sometimes the plate fail, sometimes the screws fail, and today most of us, if we do plates, we do double plating, so another exposure. You have to expose the medial part as well. Unless you do the medial arthrotomy like you did, still it's huge flaps, both sides, opening the joint altogether. I like leaving things as close as possible. I don't like to suture a lot or wait for my residents to suture everything. It takes a very long time. Another problem we had is with the screws. The screws were non-locking screws that were just floating within the hole of the nail. They used to loosen, they used to break whenever there is a non-unit, the fracture unit, because they broke, but then it's a hassle. If the screw is bulging outside and it's broken, you have to, it's a lot of job to take it out, and it's a hassle, it's a pain in the ass. And when you have a screw like that, you say, okay, now I need to take her to the OR just for this lousy screw, to take it out from her? Yeah, you have to do it. You have no other choice. So this is the problems we had. And we want to treat these fractures minimally invasive. We want to treat it only with one approach, one nail, to get it over with as quick as possible. Can we do it? Okay, I think so. This is what we have, the new design. Now, our entry point with the old nails, with the straight nail, is easy. But what happens when we have an arthroplasty? Well, we have this, the recurvatum. Why? Because the entry point is posterior. It's not in the Blumenstadt point. It's not in the middle of the Blumenstadt line. The prosthesis takes you posteriorly, and then you have this malreduction. So what was the solution? The nail design changed a little bit. They gave us the 10 degrees. You see it? Sorry. First, my mistake. First, they changed the thickness of the nail in its distal part, so you can fit most of the prosthesis design. You see all the designs are pretty much big. The smallest one are the Sigma and maybe the MG, I don't know it, which is 12. Most of them are pretty big, so our nail, the new RFN nail, which is 11.2 in its distal part, could fit most of the prosthesis design out there, and you won't have a problem. What's more important is the 10 degrees curvature. Where it is? Sorry, here it is. The 10 degrees curvature in the new design of the nail that will prevent the recurvatum in the fracture area. Now, I use a couple of times a tibia nail because of that. Because the tibia nail has the curvature, you just flip it over, put it upside down, and it can give you a good result. The problem is you don't have as many screws at its tip to capture the fracture. So if you have enough bone stock, it can work. But if you have fracture line that goes all the way distally, it will not work, and you have to go to the plate. But this is one of the solutions that Synthes offered us. And of course, the side plate. Side plate should give us, sorry, the polymer inside the nail is the one solution which should prevent the purchase of the screws. And some other design within the screw that changed is the multi-direction screws that can capture every fracture line. The polymer inside gives us more pull-up strength for the screw itself. And one thing I really love is this design where the screw is thicker on its proximal part, and the threads are bigger to capture more the cortex on the proximal part of, and of course the advanced screws, which are my favorites, which actually lock themselves into the bone and give you stability within the nail and outside the nail, so you get a really stable construct. Now about the side plate. So what does this side plate give us? The advantage of the side plate, it gives us compression and gives us stability, and gives us 4 more screws to capture intra-articular fragments within the joint, and give us more side stability. So how does it work? You have these 2 screws that go into the nail. They lock into the plate. They lock into the plate. They lock with the polymer into the screw. So you have a very stable construct. You have 3.5 VA screws, which you can direct to each direction you want to capture any fragments that you have there. So you have a lateral buttress. You have intramedullary nail in the middle, and you have a very good stable construct. Sorry. The last thing is, I didn't use it that much. Sorry. Come on. Okay. So these nuts are very good for compression T-shaped condyle fractures. I used it once only on one side to compress because again, you have a locking to the nail, so you can compress and buttress from one side. The nice solution, but I use more the side plate than these nuts, and I think it's better. So let's look at a couple of cases. This is a simple periprosthetic fracture, distal femur. Not a lot of bone stock distally. You see the fracture line all the way. There is a fragment very close to the stem, but the stem is stable. And of course, most of us would use a side plate, I think, for this type of fracture. And so I decided to use the nail, not like everybody. You see the 10 degrees curvature, which prevents the recurvatum. The side plate giving nice compression. I don't know what's your practice, but I usually shorten them a little bit. I do shorten them to compress. They get better healing this way, and it's a better solution. And although this is a locking screws construct, what I do, and this is one trick that maybe I can give you, what I do, I put the first screw as a non-locking screw. I put a regular screw. So with the polymer, it pushes the plate towards the bone and compresses it. Then I put all the locking screws inside. I take out the screw and replace it with a locking screw. And then you have good compression. And this is another case, another periprosthetic fracture, distally, not a lot of bone stock, when until not long ago, all of this will get a side plate for me. So I went for the side plate with a nail. Again, you see, nice reduction, good buttressing on the lateral side, and some shortening for good purchase, for good contact between the bones, and good healing and good callus formation afterwards. I'm sorry, guys, I don't take pictures of my patient walking afterwards. I know all of you show that, but I don't do it. In Israel, not everybody is so compliant for taking their pictures as here. Fairly simple fracture, distal femur, nothing special. I think most of us would nail this fracture. So simple resolution, nailing, that's it. Go ahead to, that's right, that's it. Any questions?
Thank you, sir. Any questions from audience? Any questions? Okay, sir. Thank you, sir. We will have a short tea break for 10 minutes and then we will proceed with the case-based discussion. We'll have a tea break, sir. we'll start with the part 2 of knee session, that is a case-based discussion. I would like to call Dr. T. Vinoth sir to speak about diaphyseal bone loss. Dr. T. Vinoth sir is a consultant trauma and endoscopic spine surgery in our hospital, an alumni of a prestigious Madras Medical College. He pursued his PG MS Ortho in Government Tanjavur Medical College and did his postdoctoral fellowship in spine surgery in Preethi Hospital. Specialized interest in adult deformity and limb lengthening procedures. Underwent spine training in Germany and reputed centers in India. Welcome, sir.
How we are going to how we are going to address significant diaphyseal segmental bone loss in young adult. What's our strategy in addressing this? So 22 male presented at a odd hour with history of RTA in the evening with a head injury, chest injury, foot, hand and lower abdomen injury also. So we started stabilizing the patient. We have to make him alive, survive. So ATLS protocol followed. From that time to the fight for survival begins. So when we see wound in the thigh, okay, we thought we can put external fixator in the midnight or we can wait and watch. There's a bit contamination in the thigh. We have given adequate wash and sent for appropriate investigation. But when we see a X-ray like this, so with mid-diaphyseal segmental bone loss, our plan has completely changed. So other remaining minor injuries, I think we can address it in routine format. Again, when the attender brings this part of bone, which was lying in the road around 8 to 9 centimeter, still more we are curious. So how to change our protocol? I would like to ask our faculty, Kumar sir, how this protocol begins here. Mid-diaphyseal segmental loss around 8 to 9 centimeter with loose fragment extruded around 4 p.m. in the evening. At 10 o'clock received in the casualty.
Yeah. Such cases like more of ATLS protocol, stabilize the patient. I'm not interested in stabilizing this patient midnight at that point of hour. But practically, I have not come across such a situation where I had a bone delivered by the patient attenders. But if this was a scenario, I'm reluctant to consider. I consider your radiological appearance a 10 centimeter defect. How am I going to start my reconstruction? So in this scenario, if it is this is my clinical scenario, I'm not aware of the associated injuries, assuming he does not have a chest, abdominal or pelvic injury. It's an isolated compound femur with a segmental bone loss. The next elective day, if this was not a run over injury, if there's no degloving in the thigh, if the muscle appears good, I do a debridement, I put a nail inside with an antibiotic spacer because it's a long segmental defect. I don't want my tissues to fall inside because I will definitely wait for a period of 3 weeks. Situations where I don't have this bone loss, if it is only within 5 centimeters, I accept shortening, same debridement, do a docking, antibiotic stimulant. Later, I do a corticotomy with a nail, fixator assisted nail, LRS, I do a lengthening. That is so till 5 centimeters, you don't come across really a pseudo paralysis of your quads. Yes. You can. But in this scenario, I would do primarily a cement spacer, then later do a transport.
Dr. Yaacobi? Yes, sir. So this is our scenario where the patient presented midnight with an unstable state with around 9 to 10 centimeter diaphyseal bone loss. So we are resuscitating the patient and the attender brought this dead bone laying by the side.
So what you see in the X-ray is not the real length of bone loss. It's what you see on the road. It's
So only
it's the real thing.
until they bring that photo and that bone, we are aware that it may be around 5 or 6 centimeter. We can proceed as Kumar sir said. But when
So
they showed that photo,
I had a similar case that the patient came over and the ENT guys brought me his medial condyle. It was in their hand and told me, should we throw it? Should we give it to you? And that was an articular surface, so we couldn't throw it away. We had to do something with it. So we just kept it in solution with antibiotic, tried to sterilize it as much as we can, and we implanted it back. It was a young patient, healthy patient, and it worked. I have no idea how it worked. I have no idea how it didn't get infected. My bet was it costed me a whiskey bottle to my colleague because we made a bet if it's going to get infected or not, and fell. And I lost, lucky for the patient that I lost. But if it's a diaphyseal segment, I won't take the risk. I won't put it back. What I would do, probably masculate, it's a good solution. Could work. You can debride, you can wash it, nail it, put cement spacer, take the cement after a few weeks out, do bone grafting. It works perfectly with femurs. Not so much good with tibias. 10 centimeters, it's a little bit more than the limit that is published. But I saw Giannotis just published not long ago a series where he did musculae even higher than 10 centimeters, and he shows good results. I will never do it on the tibia, femur maybe. If it was my case, I would spend him for a little while, maybe 2 weeks, make sure he has no infection, that he's clean, wash him of course, and debride, and then do a bone transport on a nail. Because I showed the colleagues previously, I have the option of doing bone transport on a weight-bearing nail, which it's not the precise bone lengthening nail. It's actually, it's from the same company, it's precise, but it's Nuvasive, which belongs today to Globus, but it's the same nail which has a proximal and distal attachment, and it has the sleeve for bone transport in the middle. So you can transport him, it will take him a few months, and he has new bone and will be ambulating happily.
yes, sir. Thank you, sir. So we kept all that in mind. So our plan start, let's explore the wound. If the soft tissue is okay, bone viability after preparation, everything is okay, we can reimplant. Because we also have already published reimplantation extrusion, and we had good result. Dr. Praglad sir showed we are lifting heavy weight and moving something, and we are tibia, everything. So we kept that in mind and we export, but it is a deep degloved wound. So that centimeter of bone has to be extruded, extensive soft tissue damage will be there. So our intraoperative findings changed our plan, and we moved into, as I said, cement spacer application. So this is a critical segmental defect where it is more than 2.5 centimeters circumference, the diameter at that region. So it's more than critical. So we start priming the patient because we know that the treatment may take months. As I said, we can put cement spacer, Ilizoro or LRS or nail transport, everything. It may take minimum 4 to 6 months duration. So patient should be prepared for that. And he should be keep abstention from smoking, diabetic control, everything. The other option include whether mascula can be carried out in the first stage and later on distraction osteogenesis with LRS or Ilizoro, or shall we dock that region? As I said, if it is less than 5 centimeter, I will dock it and later on transport. Since it is more than 5 centimeter, acute docking will cause pseudoparalysis, vascular, even the kinking of the vessel, everything will be a life-saving nightmare. Or we can go for primary vascularized fibular graft reconstruction with a plate augmentation. No, the microvascular trained surgeons are not available round the clock. So we moved on to various options. We have considered it: debridement plus orthofix plus shorten at that region, or later on corticotomy and transport, or debride, dog and nail it, or with the fibular graft and fixation with plating, debridement in the stage 1, nailing, and the stage 2, delayed bone grafting. But how much bone will be retained, how much will be resorbed, following that we may not know, because more than 4 centimeter, definitely bone resorption and non-union will be there. Debridement, nailing along with the cement beads or spacer, like hybrid masculae or hemimasculae. So and delayed bone grafting after 4 to 6 weeks following the cement space removal, debride, vascular fibular graft, plating. There are lots of options available to reconstruct the diaphyseal bone. So any ideal treatment should be carried out by easily. Even tier 2, tier 3 cities, the surgeon should be experienced and they should good outcome. The treatment duration for the entire, it cannot be months or years. It should be a shorter duration considering the extensive injury. It should be inexpensive, good result to every doctor, and it should be comfortable to the patient, minimal adverse effect on his health and financial status, able to ambulate yearly with weight bearing, and length and alignment should be maintained. So these are the criteria we have to consider while dealing with the extensive bone loss. So we started our protocol, worked it out and planned this. We explored the wound, extensive debridement and copious irrigation. We skeletally stabilized with LRS system. On this kind of extensive wound contamination with the void, we take them for second debridement within 48 hours or 72 hours. So we redebrided, we removed the necrotic tissue, and we applied Clemens Weiser for 7 to 8 centimeter. Following that, we have removed the LRS 4 to 6 weeks later. If there is any pin tract infection, we have to address it. And we have applied POP and immobilized it. By the time the pin tract interval itself good, otherwise there will be a chance of recurrent infection at the pin tract site. So we give 1 or 2 weeks pin leave. And by the time the bone quality improved, we removed the cement spacer, augmented it with the plate and nail construct, and autograft, allograft or synthetic graft. Everything can be kept inside the induced membrane and start early weight bearing depending upon the patient condition. So this is the wound, so extensive void and dead necrotic muscles. So this is our paper. We have re-implanted even the extruded femoral condyle and having good result. So we here prepared our bone graft and kept it ready. Since wound is not fit, we are moved with the LRS system. This is the initial picture. After 3 days, that is 72 hours, we re-exposed it and applied gentamicin, vancomycin cement, and is the final picture following the masculine technique. Later on, he developed a pin tract infection and the LRS has been removed by 4 weeks and we have been kept on POP. So since unstable bone, it started toggling. By this time itself, we are able to see the posterior cortex of the femur. There is callus formation along that membrane. So this is a good sign that he may able to retain the graft, whatever we kept in the induced membrane. So later, 4 weeks later again, we have removed the cement, take adequate iliac crest bone graft, mix it with the synthetic graft and placed it in the void. So without disturbing much of the member, antigrade nailing has been done and plate has been augmented along with. So packing the induced membrane with the graft synthetic and the iliac crest graft and try to close the membrane along with the muscles available so that the graft may not get displaced. So you can see adequate callus formation anteriorly, posteriorly and lateral. So this is, as we discussed, hemimascular technique for acute cases. Even we have done it for delayed case. So this is 3.5 months post-operative. We started mobilizing the patient since injury. So he's having adequate knee functioning. And earlier we have published these articles for tibia masculate and distal femur masculate in our study. So the conclusion is treating significant segmental bone loss without affecting the limb length and function is a challenge. Mascular technique prevents the bone resorption when combined with nail and plate augment improves the stability. Antegrade nailing avoids disturbance to the induced membrane. Careful progression of the unit should be assessed by serial radiograph. Adequate rehabilitation prevents stiffness and associated complications. Thank you.
It's very interesting. Do you do a pin track holiday or you just take it out if you see pin track infection?
Yeah, we kept the pin track holiday for 2 weeks, sir. Since he has
For 2 weeks.
proximal thigh, infected wound at that site, we kept it 2 weeks as holiday period.
So I hate the holiday. I hate the pin track. It means it takes away another OR for you. So I took the risk, and since I have the RIA reamer, I just do a RIA reamer. I take the X-fix out, do a RIA reaming, and then do my internal fixation. And I have to say that until today I had no recurrent infection and no problems with that. I hope it's the RIA and not only me being lucky. But I think it's when you do reaming and you are able to wash it at the same time, You may get away from doing the pin holiday.
Okay. Whether you will be taking RIA from same limb or opposite healthy limb, sir?
So for the same limb, I will do it to prevent infection.
Okay.
If I will need a bone graft, I will actually go to the tibia, so I won't be affecting another limb. I don't want to affect two limbs. I'll try to stay ipsilateral on the same side. But it depends which approach. If I do antegrade nailing, then it's not relevant. I cannot go to the tibia. But if I do retrograde nailing, I can go through the tibia because it's already there.
Thank you, sir. Thank you.
Next talk is again about metaphyseal bone loss. Again, I request Dr. T. Vinoth sir to have a talk on.
So following this, we will have how we address the metaphyseal diaphyseal bone loss. Similar to that, 19 male history of RTA two-wheeler versus two bus on January 2024, exactly 1 year ago. He sustained a polytrauma injury that is same ipsilateral limb. So we are able to find out a significant defect in femur even with long segmental graft, and this is a floating knee. So you can see distal fibula almost again 10 to 12 centimeter bone loss with extensive contamination and segmental fibula. So here our comprehensive classification of a CCC floating knee injury we advised, and the treatment is based on that protocol. We have to rule out vascular injury in this kind of floating knee injuries. Definitely ligament will be there. So take CT scan, look for angio, vessel patency and everything. So then it comes to be right floating knee injury, CCC classification type 2, grade 3B, M3 modifier, and grade 3B open right distal femur shaft comminuted fracture with bone loss 7 to 8 centimeter, and tibia around 12 to 15 centimeter bone loss, same limb, foot and ankle injury is also there. So this is our classification which has been extensively elaborated by Dr. Praglad sir. So we taken up for stage since femur is closed and the tibia is contaminated and the salvage of that limb, tibia or leg is very, very important. So on the day one, we applied external fixator for the tibia and fibula has been fixed with the tense nailing, and pulse lavage adequate antibiotic protocol has been followed. Again within 42 hours, we have taken for exploration, debridement and vac application for the leg wound, and at the time we have nailed the femur. Since the patient general condition has been improved, we have nailed the femur with a mini circulage wiring to keep the loose fragment in contact with the nail and bone. So you can see that fibula, we have maintained the length and alignment. Again, we cannot dock much more because sometimes there may be single vessel injury, anterior or posterior tibial. Docking or kinking may cause the limb for paralysis or even gangrene. So we maintain the adequate limb. Keeping the fibula length in alignment, we have maintained the adequate limb. So after this is a third procedure, we have taken 2 days after, we have debrided the wound and kept cement spacer for the tibia, and mild soakage was noted in the tibia wound, and hence we have explored the circulage wiring site and kept additional segment plates. So we left the patient in situ. Raw area has been extensive, therefore plastic surgery SSG graft has been harvested. So this is the final wound picture around 6 weeks post-operative. So how would you address this kind of patient with a floating knee injury, with both the femur, polytrauma, ARDS status, vascular compromise in the distal tibia? So what would be your protocol?
Interesting. Which vessel is still there?
I think anterior tibial is there, posterior has been gone.
So the fibular artery is gone.
Femoral artery is there.
Is there?
It is there. Only tibia close
So
to the ankle.
It's funny because you have a segment of fibula,
Yes.
that is exactly the size of segment you need in the tibia. It's very tempting to put a syndesmotic screw in the distal part
Yes.
to stabilize the lateral malleolus, and then release this segment of fibula. You have to cut the artery distally, unfortunately, but you can cut it and then mobilize this segment of fibula and implement it exactly where you have the bone loss and graft around it, put the plate, and job is done.
Yes. Since we have doubtful vascularity, we are very hesitant to keep touch of the fibula. Sometimes
so
it may compromise, we may lose that limb.
If you have no other choice, I don't like doing muscle in this region. Again, I'm a bone transport guy.
Yes. Yes.
How about the ankle mortise because.
So I
is
said
it
you have to put a syndesmotic screw.
syndesmotic screw?
Yeah, to this lateral malleolar fragment,
Okay.
so it will be stable. And if you put a syndesmotic screw, it will be stable. It's fine. I agree. It's a bit distal.
Yeah.
It's not the best choice, but it's a good solution for a terrible situation where you have your graft there. It's like the patient prepared the graft by himself. So if you have enough vessels to sacrifice the fibular artery, and you can mobilize with its blood supply the fibula to the area of the missing segment and bone graft it, then the solution is there.
So what I even agree with Dr. Kumar, what he told in his previous case. So whenever there is plafond or proximal tibia, we have burnt our hands whenever we tried this kind of graft.
So when will you transport that fibula, sir?
So
During primary surgery or following plastic surgery, skin cover, everything has been done, and then you will transport?
So I will use my plastic surgeon. They have their microscope, they have these the lupa glasses and everything. It's not a big issue if you want to do it yourself.
So index
But this
surgery
is a one-shot. This is a one-shot chance for the patient. So if you have only one shot to do something, make sure you have the right team with you to do that, because you will not get a second chance. If you lose this graft, that's it.
If you lose it,
yeah,
then
if
your
you
plan
lose-
will be?
You don't have many. You can find plan Bs, but you don't want to. You don't want to get there. So I will get. In these cases, you can always put the external fixator, put some antibiotics inside, go get coffee, get up next morning, look at it again, and say, "All right, what can I do? What's my plan?" And talk to your colleagues and talk to everybody, see who's available. You have time. There's no hurry. Because anyway, you know the day after everything will be extremely swollen. The soft tissue will be rubbish. And anyway, you will wait like 2 weeks for it to settle down. So you have time to plan. You have time to think.
So you have to employ AO principle here. Plan it, scan it, and then you plan it again. Yes.
Yeah, with something like that, you don't want to get in the middle of the night or even in the evening and start making your plans acutely. Span it. I agree with you that you can nail the femur as much as you can to get some stability in length. And not everything has to be external fixator. You can do it quite easily, quite fast. And the tibia have no other choice. You have to span it. I will probably go for delta frame to the ankle. I will not catch this distal fragment, maybe with one shunt screw just to stabilize it, but I wouldn't want shunt screws there because I wouldn't want to compromise that area with the chance for infection, for
We have
penetrant
calcaneal
infection.
fracture also, so we have to avoid that event. Yes, sir.
Similar
yeah.
scenario, since it's an open injury, single vessel was your worry. Usually, for the youngsters, when you have a plafond or a pylon, a remaining bone stock, please don't put your external fixator in that. Try to span that joint. In this scenario where if you have a calcaneal fracture, just do a hybrid. Take a half ring Ilizero. Just pass 2 wires. A transmalleolar wire you need not do, you not go into the ankle at all. Just through the talus, just suspend it. You can use your this regular external fixator. You can connect it to that half ring. And this is just a primary debridement and scanning. Next, if you have in-house or your colleague on a next elective day who is confident of giving you a vascular cover, taking a pedicle very high in the proximal femoral junction, if he is able to give you a free flap, I would prefer straight plate with a segmental fibula and cover it in one go with antibiotic stimulant. If not, I am basically a deformity surgeon. I use my Ilizero as a reserve tool. If these situations are not favorable, I put a 4-ring construct. In this scenario, I usually extend a foot ring, transport, once my transport reaches, covers the defect, I remove the foot ring, start off with ankle mobilization.
Thank you, sir. Kumar sir, your plan, sir?
My plan is same as hybrid fixations with fibula stud graft and foot of flap cover.
So 4 to 6 weeks later, the antibiotic cement spacer and the cement beads in the thigh has been removed, and we have bone grafted that femur area, and this is the current status. So knee manipulation and everything was done. The wounds look okay, and the femur start uniting. So we have to do something for that tibia now. So we applied, when the soft tissue cover at the distal, everything has been closed, we have to transport bone. So now we have applied Ilizarov. So sorry, now we have bone grafted it, done corticotomy and a slowly distraction. There is 2 weeks post distraction, we are able to identify the callus formation at the distraction site, and it's docking. So now here comes the problem, where this part of bone along with the tethered skin started punching, it comes out. So we waited for that wound to settle, but it's keep on, what is the dehiscence? Now the wound dehiscence starts at this region.
Normally when you do a transport, a long segment transport, and when you have a defect, it is common to anticipate invagination. This is the time you must go in, just excise that invaginated. Now you have adequate soft tissue for cover. So in toto, excise that invaginated soft tissue, utilize this interval to convert it into a docking with bone graft. So that is done. Based on your scanogram, if there is a resultant limb length discrepancy, you can still continue your proximal transport. You can make it a lengthening construct.
Sure, sir. By this time, we can see the treatment duration is around 6 to 7 months. We started in the January. Yes, sir.
So why did you stop transporting him?
The skin start pinching outside. It got invaginating, and the bone started to show its face outside.
Yeah, so this is the problem mostly when you transport with circular frames. It does terrible stuff to the soft tissue. The best situation for this patient, what I would do if it was a circular frame and you have the skin problem, I would just take the shunt screws for the K wires for the transport, recharge the Elizarov and put new ones and continue to transport him. Because the best solution for him, I would take this K wire out of the lateral malleolus, put a normal plate there, because you have problem on the distal part where it's not really healing and it's not reduced correctly. But then I will do some recharge with new K wires, new area in the Elizarov frame, and continue transporting him. And if you do a transport and you get to the docking site, don't stop. Continue impacting him into the docking site, then you won't have to do docking site debridement.
Yes,
He will heal, and then give him weight bearing and he will heal. So I'll do a recharge. I will replace the shunts and continue to transport him.
We tried that also, since they say Elizarov had burned out infection and tissues which get entrapped. But since there is an SSG site and myoplasty has been done, whatever we try, the bone started to showing its face more than 1 centimeter. So now we called, as I said, we have added foot ring, we called a plastic surgeon. When they debrided it, it became an extensive area, and patient now, around 8 months, 8.5 months, he started to scratch us. When you reveal the ring, you have to remove my ring now. So the preoperative counseling, everything, I think till now it worked. So then, this is the current status. So this area has been debrided. See, and this thing, plastic cover again we have given. So the callus is consolidating. So whether we leave as such so that the callus consolidate, and later on, as I said, we graft it with iliac crest and augment it with the plate or nail. Or we have to go primarily with nail and augment it.
In a terrible situation, when you come across many of such scenarios, and when it is already a porotic and a stiff joint, You can even salvage it by doing a retrograde.
Hind foot nail, yes.
Hind foot nail.
Yes.
So most of the times here the winner is stability. You give stability and alignment, you can bail out of the situation. That's not a regular scenario. And the previous trick which you have followed in your femur, go back to your femur X-ray. This medial cortex with the soft tissue, which is actually part of the proximal fragment.
Yes, sir.
So when you have a defect like this, when you distalize and fix, you get a fixation, you get a continuity in the cortex here, you have a continuity in the lateral above. So it's like you can give it time. It really forms bone.
Okay. No need to graft even you are saying.
Medial fragments with the soft
Soft
tissue is a powerful tool of healing.
Yes, only waited, even though it's in distraction and this thing, we waited.
See the,
Yes,
see
sir,
the.
it's good.
Yes.
Even though we have manipulated with opening and we have applied cement, but still unites. Yes, sir. Small open fracture puncture. So we waited, we have tense nail, and as I said, we underwent a hind foot nailing and augmented with a plate proximally. So this is the final follow-up X-ray. See, nicely callus form. And even though we salvaged the ankle movement, the fracture is going for union and the patient is ambulating. So these are extensive scars. So another few case, infected non-union operated elsewhere with the bone grafting even, iliac crest site infection, dynamization, auto dynamization, still no union for past 4 years. So distal screws loose. So we are able to see distal screws loose. So clear-cut signs of infection. We have removed it, applied masculate with LRS. We have done corticotomy, locking. So at present, this is the patient. So we asked him to full weight bear and walk. Till now, we are compressing it. Hope so it will unite with this. Again, 36 male with a mangled limb. Same as I said, extruded bone. We are having lot of experience with extruded bone, I think. So this patient, at the last picture, you can say 13 centimeter bone. It has been autoclaved. Tibia. So this is the segment. So masculae are discarded, soak or autoclave or irradiated and place it back. So this is again vascular. We have assessed anterior gone, posterior tibialis intact. So we have implanted it. So it is the immediate wound status following implantation. We have not lost our faith. So we given myoplasty and we have covered it. SSG. So wound looks good. This is the implanted tibia. So this distal side appears okay. This is the proximal fracture site, small combination. So we have maintained it. We have waited for long. Now gradually the bone starts to show its face. It shows minimal signs of infection. So antibiotic cement bits has been kept. Now you can see the area starts eroding. It appears to be like a small sequestrum. What next? So we have converted into Ilizaro. Again, the sequestered bone completely has been removed around the 10-13 centimeter. We have transported it. We have docked it. And we went for hind foot nailing and we have salvaged the leg.
So that's the problem when we trust. We are all obsessed by a vacuum assisted closure. It's an amazing tool. I'm not saying it's not. But the problem is we became too in love with it. Because what happens, it gives us some granule tissue, it covers the bone, it covers everything, and then we do skin graft on it. But it's not a vascularized soft tissue. It will not give you the blood supply to your bone. Eventually, it's like bones are like trees. They need the roots inside the ground to get their nutrition, and when they don't have it, they will gradually die. And I see a lot of these non-unions underneath skin grafts. Every time I see skin graft and there's a fracture underneath the skin graft, I know I'm going to have problems. So I doing a free flap in this area, such big skin problems, such a big loss of soft tissue, I think free flap is the solution. Now there's a study from Brighton by Michael something, I don't remember. He showed that if you do a vascularized free flap, fascia cutaneous flap, on a segment like that that is totally discarded from all soft tissue, you can put it back in place, put a small plate on it, put the free flap on it, and it will heal. And he had a series of, I need to look for, I don't remember what was how big the series was, but he showed a very good result with that. And I do agree with him, because when I started doing the free flaps on segments like that, the situation is totally different.
Thank you, sir. Thank you.
Thank you, sir. That was a great session. Everyone enjoyed your case-based discussion, sir. Next, we come to the end of the knee session. Any queries in this session? Okay, thank you. Next, we will move upon ankle session. I would call upon Dr. R.J. Bharat Kumar, sir, to speak about posterior malleolus fracture fixation. Dr. R.J. Bharat Kumar, sir, is a consultant trauma and spine surgeon in our hospital. Completed his MBBS from Trichy Medical College, MS Ortho from Madurai Medical College. Did his postdoctoral fellowship in spine surgery in 19. He did in Diploma SIPCOT in 2019. Welcome, sir.
Good evening to everyone. Thank you, Preethi Hospitals and J&J for giving us this opportunity. So my talk will be on the surgical indications and decision making in posterior malleolar fixation in trimalleolar fractures of ankle. So coming to the introduction, ankle fractures forms around 10% of all the injuries, and posterior malleolus fracture accounts for around 7 to 44% of all the ankle fractures. Evaluation by only a plain X-ray is insufficient, and as the study by Dono et al. Has shown that CT modifies your planning in 20 to 44% of the cases. Coming to the anatomy, the posterior malleolus completes the ankle mortise. It enhances the ankle stability, and it includes the posterior tibial plafond, which forms a smooth articular surface that articulates with the talus, and along the syndesmosis, the posterior inferior tibiofibular ligament plays a very vital role for syndesmotic stability, and its role also in rotatory joint stability is now well recognized. So coming to the indications, historical indications for posterior malleolus fixation, earlier it was advocated that the indication for posterior malleolar fixation is only when there is more than 25% of intra-articular involvement. This thought process changed after this survey by foot and ankle surgeons by the which was published in the American Journal of Foot and Ankle in 2011, when most of them advocated that more than the fragment size, their indications for fixation depends on stability and some other factors. So after the advent of CT, newer classification systems emerged. Some of them are the Haraguchi classification, which divided based upon the axial CT scans into posterolateral, medial extension, and small shell fragment, and the Botneck and Ramlet classification, which divided it into 4 types: type 1, type 2, type 3, and type 4, based upon their fragment size and extension into the fibular incisura notch. So when we go for a literary search regarding what are the factors which influences towards the decision making on fixation, some of the commonest factors which influence are the fragment size, the syndesmotic injury, the intra-articular step-off, plafond depression and impaction, and the presence of intercalary fragments within the fracture. So when we search for literature, some of the literature suggests that authors like D. Veris et al. When the fragment sizes are larger in patients with subluxation, and they have found that it is a significant factor which influences the outcome. And some authors also suggest that there is no correlation between the fragment size. So there were some contrary results with regard to fragment size. When we analyze fragment size to the incidence of post-traumatic arthritis, Vahej et al. Has shown that there is increased incidence of osteoarthritis in patients who are having posterior malleolar fragments more than 25% of articular surface. So coming to the next factor of syndesmotic instability, as I told, the posterior inferior tibiofibular ligament, which contributes 41% of stability to the syndesmosis, and the contribution to the syndesmotic stability is interrupted when the posterior malleus fracture involves the fibular incisura. So the syndesmotic stability can be restored in posterior malleus fixation, in isolated syndesmotic screw fixations also when we do a direct reduction, and usually the stability of the syndesmosis is restored by fixing it by a direct reduction method, and usually there will not be any need for fixing the syndesmosis by a separate syndesmotic screw. This was documented by studies by Miller et al. And in coming to the intra-articular step-off, and it was well documented by various authors that intra-articular step-off of greater than 1 millimeter is associated with lower AO foot and ankle scores, lesser patient satisfaction, and greater post-traumatic arthritis. Presence of tibial plafond depression and impaction causes a posterior subluxation of the anterior subluxation of the talus, and this usually redistributes the load to the anteromedial region of the tibial articular surface, and which are usually not subjected to such unusual loads and predisposes these ankles to early arthritis. And the presence of intercalary fragments, these are seen in 43% of the cases, and most commonly 64% of these intercalary fragments are seen in the posterolateral fragments. So these intercalary fragments prevents an anatomical reduction, and these small fragments need removal to achieve an anatomical osteosynthesis of large fragments. Coming to the surgical approaches for posterior malleolus fractures, so these are usually guided by the CT-based classifications, particularly the Botnick and Ramlet classifications. So there are two approaches usually followed. The traditional anterior approach which we follow is by the advantage being an indirect reduction. You use a ligamentotaxis method by using a dorsiflexion of the ankle. The advantage is you can do it in a supine position. It is minimally invasive. You can do an anteroposterior screw. The disadvantage of this approach is it is difficult to obtain a very anatomical reduction, and you will not be able to remove the intercalary fragments and reduce the plafond depression. So there are chances for injury to the tibialis anterior tendon, EHL, and also the neurovascular structures. The posterior approaches, they are direct approaches. You go directly to the area where you want to concentrate. You get a direct anatomical reduction. You can achieve a stable fixation with a plate and a screw fixation. And the advantage, if there are any intercalary fragments in the CT, you can address it very effectively with a posterior approach. As the disadvantages include the risk of neurovascular injury, and there is difficulty in reducing the anterior colliculus from the of the medial malleolus if you are approaching through the posterior side, and you have to go for a separate approach. So this is a algorithm by means of Botnick classification, where in 2 and 4 you go through the posterolateral approach, and in 3 you can go through the posteromedial approach. And this is a summary of the approaches in case of complex injuries where there are associated fractures which are involved. So we have a study which is done in our hospital, says up to 62 cases which were analyzed, and they are classified according to the Haraguchi's classification and the Botnick's classification, and these were the outcome scores which were excellent in 67% of the cases. Some of the complications which we encountered are stiffness and some delayed wound healing problems, and these were the outcome analysis for posterior fixation. The plate fixation group had a better outcome, and some of the case illustrations. This is the 17-year-old male with Haraguchi type 1 shoe fixed with the screw, anteroposterior screw, with a good result. And this is another patient where we did a direct posterolateral approach with the buttress plating with a good result. And this is the third patient with anterior subluxation, where we did indirect reduction also along with the anteroposterior screw fixation. And this is the third patient where we have done a posterolateral approach. We usually go through a posterolateral approach, fix the posterior malleus, and then come to the lateral malleus, and finally go to the medial malleus. This is another patient with a posterolateral plating along with the anti-glide plating for the lateral malleus and medial malleus screw fixation done. So the conclusion is CT scan is mandatory in all cases, in particularly if you are encountering a trimalleolar fracture, to assess the fracture pattern of the posterior malleolus. Direct internal fixation by the posterior approach helps in anatomical reduction and getting good functional outcomes. Fixation of the posterior malus should be the first stage of the surgery, as it helps in assessing the reduction in the lateral view in a better way. Thank you, sir.
Thank you, sir. We will have the discussion at the end of the session. Next, I would like to call upon Dr. Sanju Antoprabhu for case-based discussion on ankle fracture dislocation. Dr. Sanju Antoprabhu is a consultant in orthopedics and traumatology at our hospital. He did his MS Ortho in Vinayaga Mission, did his fellowship in hip and knee arthroplasty from Max Hospital, Delhi, worked as a registrar in Parvati Hospital, Chennai. Welcome, sir.
So, good evening all. Thank you Preethi Hospitals for providing this opportunity. Talk is based on ankle fracture dislocation. As you all know, compared to simple ankle fracture, fracture dislocation is more complex and it's following a high velocity injury. It also has the worst functional outcomes. So how to approach? So first we have to see whether it's open or closed. We need to assess the vascularity. Sorry. Need to find out whether it's open or closed. We need to assess the vascularity, then we need to classify, and then we need to plan how we are going to do, and we should decide our plan based on our goal. So these are the basic AO principles which we all know: anatomic reduction, stable fixation, preservation of blood supply, and early mobilization. So open ankle fracture dislocation, first is an emergency. So it's an emergency. So now I would like to change the heading to in emergency what we should do. So if it is a vascular, it is associated with vascular compromise, then we have to do an immediate reduction by applying gentle traction and restore anatomic alignment and confirm reduction with X-rays. So then we proceed with X-rays and CT scan. How to reduce? The patient knee was flexed to 90, the assistant has to support, and then the examiner has to give traction along with the ankle dorsiflexion and foot inversion. After reduction, then we should apply support slab, and then we proceed with radiograph. So in case of open injury, first we all should know, we should document and take a picture of the wound so that it will be helpful for us, and it will be also helpful to explain the attenders about the status of the wound. So compound fracture, how to play it safe. So goals, the main goals are to prevent infection, achieve union, and restore function at last. So in infection, what we should keep in mind? The infection may alter our definitive fracture treatment, and we all know that infection may alter bone healing, and if there is extensive soft tissue loss, there may be a loss of function. So role of antibiotics, how long to give? We should start from minimum of 3 days till wound closure, when to start as early as possible, and what to give? We will first go ahead with broad spectrum, mainly cephalosporins along with the metronidazole in case of any gram-negative infection if we suspect. Why antibiotics? Staph aureus is the most common organism in case of any open injury. So in case of open ankle fracture dislocation, debridement is the key. So we should not delay the debridement. So we should take a culture to rule out any infection. So in OT, we can have a pulse lavage if possible, and more than 10 liters of wash is recommended. And we should plan the skin cover based on the future incision. So we need to debride layer by layer and remove the devitalized tissue. Then we will apply the ankle spanning X-fix, and then we need to scan and then plan for the definitive fixation. So as you all know, we will put the ankle spanning X-fix along with the dressing, and we wait for the wound to heal. It's up to minimum of 3 weeks and maximum of up to 6 weeks can be given. But definitive fixation can be done only after complete wound healing. So in case of closed fracture, when to operate? It's like we need to assess the skin condition, how far is the swelling or blister. If there is a diffuse swelling, we need to wait for a minimum of 5 days to 1 week, and then we should plan for the definitive fixation. Then we have to take the CT scan to assess the fracture fragment, and then we will plan for the definitive fixation. So these are the classifications we commonly use. Then is Weber log Hansen classification, as you all know, 4 modalities: supination external rotation, supination adduction, pronation external rotation and abduction. So which one to fix first? First is the fibula or the lateral malleolus followed by posterior and medial malleolus. So here are a few cases for discussion. So 63-year female, pedestrian is a two-wheeler. So she sustained injury to left ankle, wrist and right shoulder. So on arrival her GCS was 13 and this was her clinical presentation at the time of arrival. So this was her X-ray picture. So first we did the wound debridement and ankle spanning external fixator application. Followed by we did a staged vac application for the wound. And once the wound started granulating, we got the help of the plastic surgeon to provide a beautiful flap cover. So once the healing is done, we again did the CT scan and this is the final definitive fixation after getting clearance from the plastic surgeon. So with the eminent faculties up front, what would you suggest, how you would have approached this patient?
So we get a lot of this open ankle fractures. They are never a good situation. I would usually wash them, debride them, span them, because whenever you try to put any fixation underneath this soft tissue, afterward you will get a disaster. So just span them, wait. If you cannot get a primary closure, just do what you did, a vac scissored closure. And then it depends on the size of the skin defect and the age of the patient and his vascular state. I'll decide if it's just skin grafting and or flapping him. The problem is that if you're doing a vacuum scissored closure and skin graft, you cannot put any plates there. You cannot, I won't even put screws, or maybe just suture or something. But it's preferred not to do anything underneath the skin graft. You can do everything on the lateral side. If the lateral side is intact, just put a plate, put 1 or 2 semi-smotic screws to stabilize everything, and let the medial side heal. But if you get a free flap, then you can put whatever you want there to fixate it.
Kumar sir, would you like any suggestions?
Almost same. Soft tissue defect, contamination, same debris, span. VAC is not actually for closure of the wound. VAC you can keep your wound decontaminated. That is, you need not every day change a soap dressing, which is a source of contamination. You can keep your wound dry. The next elective situation where after your inspection you feel it is healthy and you have access for a free flap, you can consider fixation. But the same scenario varies based on the patient. Similar scenario if I have a elderly diabetic patient where HbA1c is not under control, rheumatoid, these situations, once I feel there is no contamination or once I feel the wound is okay, I do sometimes a retrograde. I try to make it a 1 unit to get it healed. It depends on the situation. Young guy in a situation where I have to really reconstruct, give him function, I depend on my plastic surgeon because here the key factor is soft tissue. Yes. Soft tissue defect is the challenge for bone healing in these scenarios. So it depends in our clinical practice based on the patient age, the other associated factors all. Because we have over time, if you see, you have burnt your hands in certain situations and finally we have landed up in a reverse fashion there. So if you're able to assess the patient and the scenario is not favorable, you can consider.
So I have to ask you, because for diabetic patients, especially the neuropathic patients and the severely elderly patients, the hind foot nail, we have a high level of failure. I found out that we thought it's an amazing solution for them. Today I think it's a horrible solution for them because we have a lot of failures with it and a lot of infections with the neuropathics and severely elderly patients. And we had almost, I would say 50-60% of amputations because of that. And actually, I remember in my fellowship, there was a paper coming out from the guys from foot and ankle there, that they showed also 50% failure with the hindfoot nail in neuropathic patients. So I don't know if it works for you, it's amazing, but I'm afraid of it now. When I have an issue with the soft tissue and I still need to fixate, I started doing now the fibular nail, which is minimal invasive. You don't get the best reduction, but if it's a neuropathic patient or if it's an elderly patient, I don't really care. I get the nail inside the fibula. It gives you two syndesmotic screws. I just push the two syndesmotic to stabilize the ankle, and I do it with less than 1 centimeter cat, and that's it. And get away from there.
For me, most of the scenarios when it is not a resistant infective scenario, all the neuropathics poorly controlled, I manage with the hindfoot nail, because in neuropathic situation, the biggest challenge is stability. In those situations, like as you said, even if they give you a beautiful flap, the remaining fragments after a delay, when you go for stage 2, you see resorption of the fracture ends at the medial malleolus, lateral malleolus. You cannot really give a good ankle mortise. These were the challenges. So these, if you see in bones more proximally where you really have a good size of the fragment, there it is much easier to salvage, whereas in these scenarios, that was a big challenge. So in neuropathics, in my clinical practice, where you are able to offer more stability, it worked better, provided it is not really a resistant infection.
The problem is they don't listen to you. They don't feel any pain, and they wait too soon, and then they screw up the operation.
So all these limited ankle fixation just fly off. Most of my, if it is a closed fracture without an open wound, all my trimalleolar fracture goes for a poorly controlled diabetic patient with a tibia profibula screws. I have in the construct at least 3 or 4 tibia fibula screws, because that fracture is the first insult for them, for that joint to start behaving into or get converted into a neuropathic joint.
You take the articular surface off, or you leave it?
Scenarios where I don't want to disturb the soft tissue, I leave it.
You leave it.
Scenarios where I need to take off the medial malleolus, the soft tissue there is bad, I utilize that window to prepare and...
So yeah, if you take the articular surface off, you will get a good fusion, but if you leave it, it doesn't always work.
Actually, we cannot blind the hindfoot nail for neuro. What is it?
About the vac, I just want to say, you said you replace it every day, the vac?
No. Instead of doing a regular dressing,
Oh.
the message is like, as you said, over the non-vascular bone, the red bed, the granulation tissue which you see is a pseudo cover.
Yeah.
That really does not add supply to the bone.
Of course.
That is the advantage of, if you see all these non-vascular fibula stud grafts, incorporating well when you have a good muscle cover.
Of course.
When they give a vascular flap, that behaves well. But when you have this false granulation tissue, it does not.
It doesn't, yeah, of course.
For me, in my regular practice, I use this vac to reduce the chances of revisiting the wound. At least I give an interval of 5 days. It keeps it dry and free of cross-contamination.
Yes, of course. And you can do washing as well. You can do a vac wash.
the heat on, would still like to rush through another one patient where she is a 5-year-old girl child, pedestrian versus four-wheeler. So this was her clinical presentation at the time of arrival. So these are the X-ray pictures. So what we did is, considering the age and considering the need for skin cover, we went ahead with the child rest technique, where we aligned the ankle and then we put the transarticular Steinman pin, followed by which the plastic surgeon again did a beautiful flap cover. And this procedure flap cover was done just 2 weeks back, and she is still under follow-up. So again, I am bringing the discussion to the floor, how you would have approached this patient considering the age and the extent of injury, and how you will proceed as a post-op protocol for this patient.
Well, you brought into the field growth plate, and when you imply growth plate in the field, you change totally the picture. Well, how old is she?
5 years.
5 years.
Yes.
Oh. So I'll never use this pin through the joint, especially not the growth plate, to stabilize it. Even if she's 5 years old, your solution should be circular fixation device or external fixation or Tyler frame or whatever you can find. Give her circular frame to stabilize her. Don't put anything through the joint, through the cartilage, through the growth plate. You want to save the growth plate. It had enough injury already. And free flap is your only choice for this age, to try to salvage this leg and to give her a good function, because you can take the circular fixation off after 3 months, and at her age she will manage. She will be able to get functionality back. It will take her a while, but she will get the joint movement back. Worst case scenario, you will have to release the Achilles tendon a little bit to give her more flexibility. But I think a circular frame would be a better choice for her.
In my same scenario, if you ask me, I go with this technique. In young patients, especially, when you have this bare island itself, my plastic surgeon struggles to put a good flap or a cover. So when I put on an Elizero, it's a nightmare. So I would prefer just a single smooth Steinman pin. It does not really affect growth. If you consider this injury, there is already a 5-0 injury. So now try to find the best chance to get this soft tissue in good shape. Pediatric do well. You can even get out the Steinman pin early and convert it to a pre-molded cast. It works well. Yes, yes. For them to, if they want a frequent inspection of the flap till it matures, just make a pre-molded fiber cast, a pre-molded cast, so they can regularly remove, have an inspection and put it.
So we have to closely follow up in that scenario also.
Sivakumar sir, you share your insights.
I'll go with the same as the Steinman pin and go for the soft tissue cover, and then the flap cover.
Thank you, sir. This will be our last talk about talus fracture case-based discussion by Dr. Prashad sir. Dr. Prashad sir is a consultant orthopedic trauma and spine surgery. He completed his junior residency from PGI Chandigarh and did his senior residency from JSS Medical College and did F&B spine surgery at Ganga Hospital. Now he is in our hospital in a consultant trauma and spine surgery. Welcome, sir.
I first of all like to thank Preethi Hospital, Professor Sivakumar sir, Dr. Praglad sir, and all other consultants to give me the opportunity to present the cases in front of such a distinguished surgeons. I would like to present talus fractures, but due to the last talk and due to the delay of time, I'd like to cut to the chase and come directly to the cases. So we have a couple of cases over here. So the first case, a 38-year-old female with a history of road traffic accident. The four-wheeler toppled over. She presents to us with a Hawkins type 1 talar neck fracture with a medial malleus deltoid ligament avulsion. This is the pre-op CT scan. So may I like to ask the esteemed faculty, how would they like to proceed?
So, do you have an X-ray?
Yeah. Sorry.
Looking at the X-ray, since the ankle mortise is stable except for the medial instability and a fracture, I would utilize the same window. I utilize the medial side window to enter and address the fracture. This fracture actually you can do it percutaneous. You can use your medial window to assist if there is comminution. I was looking at the CT, I couldn't see any comminution there.
There was no comminution.
So doesn't require a plate. So you can just utilize that window, assist your reduction with that window, do percutaneous fixation and repair it, put your deltoid back. I usually add an internal brace for this after a repair with anchor. I use an internal brace from the malleolus to the talus to protect my deltoid repair.
Why won't you just let it heal?
Point well taken. If most of the scenarios in a fracture situation with the in the knee MCL injury with a fracture or a deltoid ligament associated with the bimalleolar or trimalleolar, it heals. It heals. But since here, if this talus fracture was not there, I'll be little slow in terms of, since there is a talus fracture, I can very well use this small window to utilize.
So I think I would only put 2 screws to the talar neck, percutaneous. Probably that's it. Usually anterior to posterior. I know there is some studies show that there's a better grip if you go posterior to anterior. I never done it before, so I never tried it before. So I won't say I would be afraid of it going from posterior to anterior. But they do show that it's better grip. And this is what I learned, you know. This is how I was taught before. Had Professor Niska was my chief officer when I was resident. He was a foot and ankle expert. That's what I learned from him, and that's my practice. That's what I'm used to.
So it's the same that we did. We put 2 anterior-posterior screws percutaneously, as well as repaired the deltoid ligament using fiber wire. So this is her immediate post-op. So what will be the post-op protocol for this patient, can I ask? What should be the post-op protocol?
So when you see the fractured lines like this post-op, it's not a good situation. It means something. The reduction screws actually moved the fracture line. They didn't compress it. And here you want stability and compression. If I would see this picture post-op, I might revise it. I will do a CT scan again and see the position of the talar neck. The problem is that if you want to revise it now, It needs to be open and maybe even with the lateral plate.
Yes, sir. CM pictures. This is CM pictures.
Most of the times, if I decide on fixation of femur, neck or talus, I don't hesitate to make a small open if there is little mismatch in the reduction. So actually that medial window which I told you, no, that really helps you. Actually, it's not a compromise of reduction in neck or here in talus.
Thank you, sir. So we kept her non-weight bearing for 6 weeks, her 1 month post-op follow-up, then partial weight bearing for another 6 weeks, 2 month post-op. Now this is a recent follow-up at 5 months. The fracture shows good union and no evidence of any avascular necrosis. May I ask whether when do you suspect avascular necrosis, and do you want to go for an MRI to confirm, or
as long as my patient does not present with symptom, I'm not interested in chasing for AVN, be it the acetabulum fracture or the talus.
Okay, thank you, sir. So another case, recently operated 1.5 months back, 41 years old male with an accidental fall from height approximately 20 feet, who landed on his feet. This is his pre-op X-ray. So we have a talus fracture with a medial malleus fracture. This is his CT. Hawkins type 3. So we went in with K-wires in the calcaneum for destruction, as well as K-wires in the body, talar body, to help in the reduction. We have opened both anteromedially as well as anterolaterally to get the reduction. There was a bit of a dorsal combination and the medial combination. And as there was a medial malleus fracture, that's a medial malleus osteotomy as well. So this is his final fixation. We are carefully following him up with non-weight bearing. This is his recent follow-up at 1 month. So, any suggestions?
Was it an open?
It was not an open.
Okay. Usually, most of the times, this extrusion posteromedially is associated with an open injury, or skin tenting or blisters, or there's a simple in-out wound. Okay, and it's always associated with this medial malleus fracture. So yes, here the trick as you did is reverse the force, that's the trick for reduction. Take a nice posteromedial exposure, explore the vein, nerve, artery. You get a good space to reposition this extruded fragment. And when you have calcaneum next to you, why are you worried? In this comminution, you have done a fantastic job. Always pick something from there and drop it there. You need not, because sometimes, no, in these comminutions we see fracture ends resorb. Our intraop on picture, fantastic compression you will have. Clinical inspection, you have 2 windows open, you will see. But when you see in successive follow-up, sometimes you see bone resorption. So add this trick always, that is, use these small triphynes. Some of these people have a small tryphine to harvest from the calcaneum. Add and then get it, because it's already open, extruded. So you're putting back, easily you can pack some cancellous graft and then close it back.
Okay. Could you have changed the plan, any plating, anything, or 2 screws?
When you have an approach both the sides, which you have always these small hand fragment, mini fragment, 2.4 fragment plates are there. You can very well contour it nicely. And see, in comminution, you add stability, that's our you saw the previous presentation where sir had presented all these non-unions, condyle non-unions. That extra plate, when you add stability, that is the magic for healing. So when there is a comminution, don't hesitate. And you have the exposure in front of you. Add a small fragment plate.
Thank you, sir. Thank you, sir.
Well, I have nothing to add. You summarized that pretty much.
Thank you, sir. Certificate. The delegates can get their certificates by scanning the QR codes. Scan. Yes, sir. We'll proceed with the video demonstration of femoral neck system. Now we will be playing the video here. Followed by we will have a workshop session in the nearby hall. You can see that video followed by.
Should be considered. The lateral incision is based on the following landmarks: the femoral neck axis, the lateral border of the proximal femur, and the intersection line shown in green. The lateral stepped incision for implant insertion begins 1 centimeter proximal to the horizontal intersection line and extends 5 to 6 centimeters distally and slightly posterior to the central axis of the femur. The iliotibial tract and vastus lateralis muscle is split lengthwise. The split soft tissue is protected, exposing the femur with the periossteum left intact. To maintain the retention, pin wires must be inserted from the proximal area of the brachial trochanter and directed either slightly ascending into the posterior or anterior part of the femoral head. screw, followed by the Eyal screw, as is now demonstrated. Note that if the Eyal screw is inserted first, it is crucial that the plate is aligned to the femoral shaft prior to screw insertion. Under image intensification in the true lateral view, it is verified that the plate is parallel to the axis of the femur. If necessary, it can be confirmed by palpation. The implant and insertion instrument is rotated until it is laterally aligned, ensuring that the modern screw insertion is bicortical at the level of the femoral shaft. The protection sleeve for the locking screw is inserted into the most proximal hole of the insertion band. Observe that the protection sleeve is in full contact with the handle when completely inserted. The 4.3 mm drill bit is inserted into the protection sleeve and the screw length is read directly off the drill bit. Alternatively, a depth gauge can be used to measure the bicortical screw hole. Note that the screw length should be chosen at least 4 mm longer than the measured depth of the hole. The locking screw is initially inserted under power, and final tightened with the 4 mm torque limiter. An audible click is heard when the screw reaches the 4 mm limit. The protection sleeve is removed by pressing the head of the sleeve together while pulling. The steps for an anti-rotation screw insertion will now be demonstrated. The fixation sleeve is passed over the back end of the drill bit. In this exercise, the fixation sleeve is set to 85 mm, which corresponds to the implant length and the depth of the hole. The assembly is inserted into the insert, and the hole is drilled until the fixation sleeve comes to a stop. The 85 mm anti-rotation screw is now reinserted with the 4 mm torque limiter, and the audible click is heard when the screw reaches the 4 mm limit. Clinically, image intensification is taken to verify anatomy. Interfragmental compression may be applied intraoperatively. The multifunction rod is inserted through the wire with the anti-rotation screw, and it's then inserted with manual top-right thermos. The right screw of the insert is now returned counterclockwise to apply interfragmental compression. Implant. Implant size and positioning will be verified under image intensification before reimplanting. To remove the FRS implant, the standard screwdriver T25 without torque limiter is attached to the large hole. And remove the
Thank you. So the same video we can try a demonstration on bone model in the next hall. There are four models are there. You can try. And finally, once again, I thank all delegates and faculties for coming to our hospital for this spotlight session. And thank you for J&J team, AV team. Thank you all.